Thank you. My name is Odell Lewis, and I'm a prostate cancer survivor. I'm 10 years cancer-free. And for the last 8 years, I've been involved in a project down in Montego Bay and in Kingston, Jamaica, where we've screened over 3,000 men since 2012. And all of that screening has been done free of charge. We have done a lot. We're not finished. As a matter of fact, we're going to pass those numbers because Monday the 25th will be our annual event, and we are looking to at least come up with about 800, 900 men to be screened. Mr. Farrington has seen some of the pictures of the men lining up at 5 o'clock in the morning around the corner, coming to get screened for prostate cancer, aggressively coming to get screened for prostate cancer. And that's the good thing about screening for prostate cancer. Once the men find out how important it is, they're ready to come and get screened because they know it's a life-saving event. We always say is early detection, of course, is the key to survival. So I welcome everyone this morning. Appreciate you coming out this morning early in your attendance. And I want to just, without further ado, take a moment to welcome our leader, our captain. You know, every team has a captain. You know, I was in the military, the captain was always the company commander. He was the man that set the stage for what's going on. And I think we have a wonderful company commander here. Wouldn't you say he'd be on the level of a captain? I think so. I don't know about you. You know, we had, and in basketball, you know, we had Dr. J and these other doctors and so forth. But I just want to nickname him Dr. T. Now, is that all right with you? Is that all right with Dr. T? So without further ado, I want to introduce our leader, our captain, our Dr. T. This is Mr. Thomas Farrington. And ladies and gentlemen, let's stand up. We stand up for the national anthem and all these other things. Let's stand up for this black man right here this morning. Stand up for him and give him a round of applause. And thank you, Thomas.
Thank you.
God bless you, my brother.
Thank you. Thank you, Odell, for that kind introduction. And I'm a captain now, so it's good to be a captain. So good morning to everybody, and welcome to the second day of our 13th annual African American Prostate Cancer Disparities Summit. As Odell pointed out, this is the day, the second day of a two-day event. And we're very much excited about what we were able to do yesterday, and we're excited about what we're going to do today. I want to welcome those of you who are here, and I want to welcome those of you who have joined us online. And I want to also point out the fact that Odell Lewis has been one of our very active and supportive members of the FIN network. Odell has been here in D.C., worked with Washington University. I think you were treated there. Is that right, Odell? And then decided that he was going to take a long vacation to Jamaica. But I think his commitment to prostate cancer led him into taking a leadership and a very active role in Jamaica. So every year, Odell and I will communicate about all of the great activities that he's leading there. So let's give Odell a round of applause. I also want to mention that we outreach across the country, and we do that because we have a team of prostate cancer survivors who make up our FIN network. They're survivors and their family members, and they're the ones that carry out the work in the trenches. We can do a lot of things and be very creative with our ideas and concepts in Boston, but we must make them work on the ground. And in order to do so, it's our network team that makes that happen. So I want to give a round of applause to all of our FIN network members today and ask them to stand, the members of our FIN network that are here. Let's give them a round of applause for all of the great work that they do. These are outstanding men and very committed to the cause of eliminating the prostate cancer disparity. And as I said, they do great work. Congressman Gregory Meeks, who is our host both today and yesterday, is always with us on this day. He will be with us a little later today. I got a note from his office that he would be here at 10 o'clock this morning. So we will kind of interrupt our program or have him sit and watch it until we get a time that he can join us and make his remarks once he arrives. Yesterday, it's 3 sessions of our 5-part summit. We talked about increasing the African American participation in prostate cancer clinical trials. I think we know that we have a very small participation, typically less than 5%, so we've focused on that as one of our major initiatives. We had a great session yesterday on that subject. I think we made some good progress. We understand some of the challenges that we have before us, but we were able to bring together the industry, the government, and members of our network to talk about that. And I think we have forged a relationship that's going to allow us to move forward aggressively on that area. We then talked about how the treatment paradigm has changed for prostate cancer, let's say over the last 5 to 7 years. You know, when I was treated back in the year 2000, there were a lot less options than there are today for prostate cancer treatment. And so we had a chance to go through those with Dr. Lee and Dr. Freeland, who were able to talk about how things have changed and where we're headed in the next few years. I thought they did a fantastic job with that. Then our third session, we looked at the cost impact, because as we have developed all of these great new treatments, what happens is that they are relatively expensive. And we have to figure out ways to make sure that we have access, especially black men who have the highest risk of being diagnosed with and dying from prostate cancer, have access to all of these new therapies. So we had a great session on that. Today we're going to begin looking at a responsible approach for prostate cancer screening in Black America. Those of you who were with us last year remember that we had the chair of the U.S. Preventive Services Task Force, Dr. Bibbins Domingo, with us, and we were advocating that the guidelines against screening for prostate cancer be changed and to ones of recommending aggressive screening, especially for black men. Since that time, in May of this year, the task force did change. They made a change with the draft recommendation. The draft recommendation states that men should talk with their doctors about screening. And, you know, the draft statement didn't take us where we wanted to go, where we had advocated, but it's a step forward. And that's the first session that we're going to look at today, is a responsible approach for screening in Black America. And then our fifth and final session will focus on our faith-based initiative. The way we outreach around the country, to a great extent, is with our church partners. We've been doing this since 2009 in a formalized approach with our Father's Day rally, and we have started some new initiatives in the last couple of years. And so we will hear about those initiatives and hear some firsthand experience about our faith-based initiative, and then look forward to things that we can expect beginning in 2018. So those are the 2 sessions that we'll have today. And I think that you will get a lot out of this, and it will set the path that we will follow, especially over the next year and the next few years. So I am going to, at this point, ask Mr. Azell Martin to come up and get that session started. And as I mentioned before, Congressman Meeks will join us a bit later. So Azell is a member of the Finn Network out of Boston. He's very active with our activities there, and he comes to our summit, and we're pleased to have him. So Azell Martin.
Good morning, everyone. I'd like to thank Tom Farrington for giving me this opportunity to introduce our moderator, Jock Carter. Dr. Jock Carter serves as attending physician at Beth Israel Deaconess Medical Center in Boston. and is assistant professor of medicine at Harvard University Medical School from 2005 to 2014. He also serves as medical director of prostate cancer screening and education programs at Dana-Farber Cancer Institute of Boston. He has earned his degrees from Howard and Georgetown University, also in Washington, D.C. Dr. Carter completed his residency training in internal medicine at Beth Israel Deaconess Medical Center of Boston, followed by a graduate program at Harvard School of Public Health, where he received his master's in public health degree. He then completed a clinical fellowship in primary care medicine at Massachusetts General Hospital. Dr. Carter serves as senior physician on medical services at Beth Israel Deaconess Medical Center and assistant professor of medicine at Harvard School of Medicine. He is also a medical director of prostate cancer screening and program at Dana-Farber. In addition to patient care, he also has related activities including teaching, medical students, serving as a preceptor for residents, acting as a liaison in various community health programs, and serving as a member of the Internship Selection Committee. Dr. Carter has twice been nominated for Harvard's Prize of Excellence in Teaching. I give you Dr. Carter. Thank you.
Okay, thank you very much. Good morning. Good morning. Thank you very much, Azal, for that introduction. As Tom mentioned, the issue around prostate cancer screening and people at high risk, primarily African Americans and men with family histories, is still very controversial. We got sort of smacked in 2012 when the task force said not to screen any more people because we knew that African Americans were dying at a rate significantly higher than those of white men. As Tom mentioned, we had the head of that task force here last year. I moderated that session, and we talked about that issue. And apparently they took some of that to heart because they drafted new regulations that sort of gave a little bit more leeway to possibly screening men at high risk. As Tom said, not enough, but a little bit more. We started to say, maybe talk to these men, have some discussions, look at men as individuals, not so much in a population science way that we in public health do, but as an individual, patient to patient, as we in internal medicine do when I'm talking to one of my patients. A different feeling altogether. Medicine and public health are very close, but not the same. So, new studies have come out just in the past 2 weeks of the study in the Annals of Internal Medicine where they tried to look at the PILCO study that the task force originally based its recommendations on and said, what can we do to get rid of some of the contamination in that study? So they created some models. And those models sort of said that if you got rid of the contamination in the PILCO study, by contamination, for those who don't know, the study was contaminated, so the people in the screening group and the people in the control group all ended up being screened because when the word got out that screening made sense, even the guys who got routine care started to be screened. So it was very tough to tell the two groups apart. So to try to come up with recommendations and a summary, clinical summary on a study where all this contamination is going on makes the study very muddled. So 3 weeks ago, a study came out where they looked at ways of modeling and trying to get rid of some of the contamination. That is to say that if the contamination didn't occur, what would be the outcome? And the outcome would be that between 25 and 32% of men lives would be saved if in fact that were done. Now, That's a published study in a peer-reviewed journal, one of the best journals in the country. But even that is controversial. It got past the screeners, but even it's controversial now. And people are sort of saying it doesn't make sense that you can't go back and look at real data and create a model that's going to contest the data. So we still got a whole bunch of controversy in screening, but we're not quite where we were a few years ago, but we're not where we want to be. So this morning, we're going to have 3 presenters, all of whom are outstanding in their fields, help us sort of tease this out a little bit more and talk about where we should be with men at high risk, that is African-American men with prostate cancer. So I'm pleased to, if I get this, I'll make this work. I'm going to call for some help in a minute. Can I advance this from here? Oh, it's advancing. Oh, not here. Okay. Thank you. Okay. So the title of the talk, of course, is Prostate Cancer Screening in Black America, a Responsible Approach. And our first presenter is Dr. Walford Rayford, who is Chief Executive Officer of the Q-LEAP Health Program from Cordova, Tennessee. He's a urologic oncologist and has devoted a major portion of his professional career dealing with disparities in health. He's particularly interested in prostate cancer and men's health. He's also an associate professor in the Department of Preventive Medicine at the University of Tennessee. Dr. Rayford, come up. Next we have, welcome, Doctor. Next we have,
Dr. Davis is not here.
oh, okay. Dr. Davis is not here, okay, thank you. And next we have Dr. Pamela Coleman, who most of you know. Dr. Coleman is the current interim chief of urology at Howard and assistant professor in the Department of Urology at Howard. She did her undergraduate work at Georgetown, De La Jolla, and obtained a medical degree at Howard. And she's principal investigator and co-investigator on a number of clinical studies dealing with prostate cancer. She's been actively involved in screening. The university has been actively involved in screening high-risk men, and we're certainly happy to welcome Dr. Coleman, who I know is here because I spoke to her. That's it over there. So we're gonna start maybe with Dr. Rayford presentation, and you can sort of do it here if you like. Yeah. Followed by Dr. Coleman.
Say again? This doesn't work. All right. Does this work now? It works. All right. Good morning. My flight arrived early this morning, but my bags didn't. So I apologized to Tom when I first saw him this morning about my attire. So ordinarily, I would be in suit and tie as you all are, but nonetheless, I'm here. And not only am I here, I consider this a distinct honor and privilege to participate in the 13th Annual FIN Conference. I do consider this an honor. What I'd like to do is to take you through my journey with prostate cancer screening, and to give you a historical perspective of where I started after I completed my fellowship training not far from here at the National Cancer Institute, then to the Louisiana State University, and now I am in private practice in Memphis. So I hope you enjoy the journey. One of the things that has kept me highly engaged and highly motivated in prostate cancer disparity and inequity research has been this slide here, which very basically shows that despite the progress that we've made in medical sciences, there continues to be a huge disparity between the outcomes of African American men and men of other ethnic groups with respect to prostate cancer. And this outcome difference has really not changed much throughout the years. And unfortunately, we can substitute prostate cancer with other forms of chronic diseases as well. When I was on staff at LSU, this is one of the slides that we frequently use to demonstrate the importance of prostate cancer screening, and that is early detection saves lives. And we don't want family members to go through what's shown here, and that is the man is faded out because he has been a victim of prostate cancer, leaving behind his spouse and his children. So I directed a program that we call the Louisiana Education and Early Detection Program. And this program was a community-based program where we did as what the FIN is doing, and that is we engaged the community through church efforts, as well as very frequent symposia. And in this conference, we engaged the women because we recognize, at least here in America, the major provider of health care in households, in most instances, is the woman. One of the questionnaires that we provided to over 500 men in New Orleans was, how do we encourage participation in prostate cancer screening efforts? And the most common mechanism is education. If we educate men about the importance of prostate cancer screening, then they're more likely to participate. Secondly, knowing that there is a cure for disease. Those two, education and knowing that there's a cure, account for the majority of the reasons to get men to participate in screening. And this finding was regardless of whether we were talking about African American men or Caucasian men. We then asked, what are some of the barriers to participation? And even in New Orleans, one would be surprised that the number one barrier was they feared the rectal examination. And that barrier was not only most commonly seen in African American men, but also in Caucasian men as well. There were some other barriers that included inability to get off work, lack of transportation, and some that are listed as well. But fear of side effect was noted to be a minor barrier to screening for both races. We then asked women, well, what do you think would encourage men to participate? And two things that jump out. One, with respect to spouses of men, the more common reasons were we need to have a discussion about prostate cancer in the home. So there needs to be a family discussion. And secondly, we need to provide education material. Again, this underscores the importance of education in the whole process of screening. And oftentimes, when we have our family reunions, rarely is there a discussion about health. And in fact, at a family reunion, that should be one of the more important part of the gathering. So the first set of results represent women who were married to men. The second results, and the same results were seen in women who have family members who should be participating in screening. And we receive the same results, and that is family discussion, and we need to do a better job of educating men. And then we ask, well, since you have these feelings, do you really have an influence on the decision of men? And overwhelmingly, most women state that they have a significant influence on the decision of men to participate in early detection efforts. Well, over the last couple of weeks, we have been ravaged, or at least the continental United States, about Hurricanes Harvey, Irma, and now Maria. Well, in 2005, I unfortunately was impacted by Hurricane Katrina, when Katrina had a direct impact close to New Orleans, where I was practicing at the time. And just a slide to demonstrate the devastation that was occurring in New Orleans. But that hurricane resulted in my leaving academia and going to Memphis, where I practice now. And Memphis is home. So I went back home. But my interest in prostate cancer didn't leave or didn't remain in New Orleans, despite the fact that I'm not associated initially with an academic institution. I am now. I'm very interested in men's health, and particularly prostate cancer. So one of the things that's very interesting now is we all recognize that prostate cancer grows at very different rates. In other words, prostate cancer is very heterogeneous cancer. It grows at the rate of a snail up to airplane or jet rate. The question, the challenge, is how do we determine the aggressiveness of prostate cancer when we first diagnose men with this disease? That's what I'm interested in now. There are a lot of markers that are involved with the early detection of prostate cancer and how we can further stratify men with this disease. And certainly time does not allow me to go through all these markers, but I do want to share with you some of the results that I've seen within my own practice. If we believe that cancer represents uncontrolled cellular growth, then one of the markers for risk stratifying men with prostate cancer is to look at a set of genes that are involved with cellular growth. Those genes, which represent approximately 28 genes, are within a panel affiliated with the Polaris test. With this Polaris test, we're able to then look at the genetic expression of the cancer, of the genes within the cancer, and we're able to provide a score based upon the number of genes that are expressed and the level of expression. The higher the score, the more aggressive the cancer is. And what this histogram shows is that African American men seem to have a higher score than men of other ethnic groups. And we've seen that in various clinical pathological findings that have been published. Also, if we were to look at the 10-year risk of dying from prostate cancer just based upon the Gleason score, comparatively compared to the 10-year risk of dying looking at what's called a combined clinical risk, which represents a combination of the CAPRA score, which are a number of clinical pathological features. In addition to the genetic expression, we see that this panel of genes is able to further stratify man based upon that Gleason score. So we then can identify a man who has a very low risk of dying within 10 years versus another gentleman who has a 50% chance of dying in 10 years. So this information can help us recommend whether an individual should undergo active surveillance or whether he should undergo more forms of definitive treatment or even multiple forms of definitive treatment. So this test, African American men had higher scores. What I didn't show you was African men are more likely to be reclassified to higher scores, and scatter plot shows that we can use this test to further discriminate how aggressive the disease is. Another thing that we've been doing within my practice is we've been further stratifying prostate cancer. So prostate cancer is just not one form of cancer. We're now able to determine that the cancer actually comes from various portions of the prostate gland, from the basal portion and from the luminal portion. Then there's some types of cancers that are much more aggressive, which are referred to as neuroendocrine or small cell cancer, than other forms of cancer. So in other words, we're now able to further identify where within the prostate gland the cancer originates from. And I show you this slide only to demonstrate that despite the fact that we're all African Americans, we're all not alike. And that is the expression profile of these various forms of cancer differs geographically. So it's very important to be able to do these types of studies, not just in Memphis, but all over the country, because the differences may have an impact. And I show this slide because here we look at the genetic expression of certain types of genes that are known to be different from African American versus Caucasian American men. And what it shows, what I want to try to show, is that when we look at men who have low risk cancer, the expression profile in these men is very different than the expression profile in a Caucasian man. That means African American men who have low risk disease, their cancer is very different than Caucasian men who have low risk disease. So if we go back and look at screening, then one would intuitively say then the screening recommendations possibly should be different. Now, as what has already been mentioned, there is a huge challenge, and that is there's an underrepresentation of African American men in clinical trials. And I tried to demonstrate that one, that there are geographical differences, and secondly, that there are racial differences. Therefore, you really can't generalize African Americans in the you can't put us all within the same group. You have to do some studies that are specific for African American men. Now, unfortunately, as what has already been stated as well, a tremendous underrepresentation in many of the studies that have gone on to make recommendations about prostate cancer, but unfortunately, they've had a very small African American participation. The Parton tables, 7 to 12% African American men, which only represents 665 men. The D'Amico tables, and the Capture database, which represents one of the largest databases for men with prostate cancer, only has about 1,200 men out of about 14 or 15,000. So there really needs to be an effort that pulls all of the experiences of African American men across the country. And once we do that, then we can start looking at how we can do that from a global perspective. So what can we do to address prostate cancer screening and early detection? One, we need to mobilize the community, and I think that's one of the topics at this conference. To improve or to increase their awareness, We need to encourage men to discuss prostate cancer within their family as well as with their healthcare provider. And we also must make sure that we continue to offer prostate cancer and encourage screening PSA tests and the rectal examination annually, beginning at the age of 40. That's it. Thank you. Am I to take questions now or
No, at the
later?
end.
At the end?
How are you?
Okay. Thank you. Good morning. I would like to thank Finn again for having me here for your 13th annual conference. And as was mentioned, I'm right here in Washington, D.C. We're right here in the thick of things where we have a very large incidence and prevalence of prostate cancer. So let me tell you what we've been doing here at Howard. I'm the director of the Mentake 10 Center program. I don't have any disclosures to put out there. But basically the Mentake 10 program, if some of you all haven't heard, is, probably takes less than 10 minutes to actually get screened for prostate cancer. And so we have named our program that. And this is actually came about in the 1990s after one of our research colleagues, physicians' father, was diagnosed with prostate cancer. And the focus at that time, now we're talking back in the 1990s now, was bringing awareness to prostate cancer in addition to being a resource for men who were seeking information about prostate cancer. So our program at that time involved doing both, as we still do now, the PSA and the digital rectal examination. And we were targeting men over 40 years of age to come and get screened. The program took a little bit of a turn in 2005. We were able to not just offer PSA and DRE screening and testing, but we were able to add to that, especially with our community outreach, some informed decision-making. And informed decision-making is kind of a really big term, I think, because if anyone here has ever had any procedure and you are to sign an informed consent, I don't think you really ever know what that is until you've had the procedure and actually gone through it in terms of really knowing, to being able to inform you about everything. But it really doesn't take that much time, actually, we'll discuss in terms of informing men about decision about having screening. So we were able to benefit from a grant in 2007 from the CDC and the Department of Health, was awarded to the Howard University Cancer Center for us to be able to purchase a mobile unit and to be able to go out into the community and do prostate cancer screening. The first unit had 3 small exam rooms, and then in 2012 we were able to actually renovate and have a reception area. We actually have a phlebotomy site station, bathroom, 2 exam rooms, and most of the appliances were upgraded. So this is our Mentake 10 unit is actually here today, and we are doing screening in Exhibit Hall D. And it was very interesting because a gentleman came this morning and asked about prostate cancer screening. A friend of his was screened yesterday. So there we have it. Takes each one, tell one. And he came this morning looking to get screened. So I thought that was, that was just wonderful. So this is just a picture sort of our Mentake 10 mobile unit screening unit. And this is the inside where you can see we have an exam room, a phlebotomy table, if I can find the pointer, and place to wash your hands, things like that. So this is another view of another exam room that we have. So this is actually in a big unit that moves from around town that we can take 2 men for the screening. And you'll see from a study we did that's very, very important. So outside of doing the PSA and the DRE, we also provide information at that time. So when the patient, when the man comes in to be screened, he fills out a questionnaire, and the questionnaire is then reviewed, and the discussion, informed consent is had with the patient at that time. We also screen for other cancers too. We do lung and breast cancer, but particularly today for talking about prostate cancer. And the gentleman that came earlier this morning, he was like, well, when did you screen? I said, well, we normally screen, we used to screen twice a month. Now we screen the third Wednesday of every other month. And like here, like I said, at the Congressional Black Caucus, we're screening, and we've screened before the NBC Health for Fitness. It was interesting this past year, the NBC Health for Fitness, because of the U.S. Preventative Services Task Force recommendations not to screen, we were the only people there at NBC4 that were screening. And I think I did 75 digital rectal exams that day, which was great. But the other, this finger gets the workout. But urology's fun. I like to make it fun, right? But none of the other hospitals in the area participated in the prostate cancer screening. So we had men lined up around the hall waiting to come in and get screened. With our program, with the grant that we obtained, we're able to screening is free for any uninsured participants. And after the screening, the patients, we get their phone number, address, information. After the screening, they get a copy of their PSA lab work and a letter signed by me, whether or not that this seemed to be with the normal limits and the DRE was normal, or whether or not they need to have additional be seen by either their physician or primary care doctor. And if they don't have one, we also offer navigation through our system at Howard to get them taken care of. So our program today, we have some data to look at, and we have lots of data. And I was just telling someone earlier this morning, we actually need a couple of research fellows to come in and help us sort out this data and get this information. Because I think this is kind of information that would definitely have been helpful to U.S. Preventative Services Task Force in looking at, not giving us a grade D or a grade C for screening for prostate cancer in African American men. And our data is going to be presented actually by one of my colleagues, Mr. Clinton Burnside, next week at the Association for Cancer Research in Atlanta, Georgia. So I'm not going to steal too much of his thunder, but just to show you a bit of it. So over from 2009 to 2015, because in the 1990s, I must admit, we weren't keeping some of the data that we could actually be able to look at it. But from 2009 to 2015, our database included more than 2,300 cases. And we had information on the patient's history, also on their BPH. You've heard of the AUA, Quality of Life Symptom Score Index scale, their DRE results, the PSA values at the time of their screening. So one of our first abstracts, as I mentioned, is going to be presented next week. But let me just tell you a little bit about what we found out. So after the, for us, after the recommendations from the U.S. Preventative Services Task Force, there was a significant change in our program utilization. 57.4% of participants were screened at community-based events. So not even coming to the cancer center, but at community-based events. And I want to just really sort of harp on that. The mean age was 56.6 years. Most of them, 84%, were African descent. And just some other facts. 2 out of 3 patients had medical insurance. About 40% had a primary care doctor. And 22% or so had a family history of prostate cancer. Now, other residents that we screened, very interesting, most of them resided in wards 5, 7, and 8, which are our highest wards incidence for prostate cancer. So they were coming in. So this is our abstract, and that mentions some of those numbers, but what I want to bring to your attention, if I can forward, are the conclusions that we actually had an increase in the number of men coming in for screening after the, not this last initial draft, but in 2012, the U.S. Preventative Services Task Force warning and also terrorizing people about not screening. I brought my family medicine resident with me here today who, for up until this past May, family medicine, internal medicine, their academic center said, no more screening, don't do it, you're harming patients. We're just talking about screening, PSA and DRE. No one even mentioned about going forward with a biopsy or anything like that, but just potentially screening. They had completely stopped screening. But now I think he feels a little bit more comfortable about screening with, like I said, quote, an informed consent. So from our data, the takeaway message was that targeting the community seemed the kind of a best place to go for providing appropriate education and may increase health awareness. And I thought about it, and I think there's a couple of reasons for that. One is that in the community, and like this patient this morning was a prime example, someone in his community actually said, I got screened yesterday, it wasn't bad, less than 10 minutes. And he said, okay, I'm gonna come in today, I'm gonna find out where I can get screened. So there's a certain amount of bonding to some degree that goes on with in any site, in any community with any healthcare awareness issue. In that bonding, if we can inform and educate, we've heard earlier, this patient can next go and inform and educate that patient. It really wasn't that bad. The DRE really wasn't that bad. The blood drawing the PSA wasn't that bad. I was in and out in less than 10 minutes. It also helps, I think, in the community for patients to come in contact with each other. They're not alone. They're not the only one. They feel, I think, a bit more comfortable, and I think that's why some of our community screening is very effective. And then we do often screen a lot at church activities. And the church, as we know, is for I think, myself and African-American communities, sort of like the heart, the center of where things happening. And it's interesting, I like the concept of the family reunions, having some healthcare education awareness, during that event, which is always so much fun, but also is a moment that we can teach one and educate one and perhaps screen one. And then in the community, when you have everyone else involved and people more comfortable about getting screening, they're more likely to participate in the screening. So I think community outreach is very, very important. And we are still going to continue our prostate cancer screening at Howard University. Thank you.
Thank you very much, Dr. Coleman. So, two things struck me as from our two presenters. One was that both spoke about the need for education and awareness. All sort of comes together. Another thing is that it was interesting the points from Dr. Rayford about that survey you did with the men, that both the white men and the black men didn't want the DRA, about equal, but the black men couldn't get off from work, indicating, socioeconomic piece to the screening part, that they had jobs that maybe didn't allow them to take time off from work. But the real thing is the big differential in the fear of the needle from the black guys. Now, I ran a program similar to Dr. Coleman's program for 10 years in Boston, and many guys came on and refused to get the DRE, the digital rectal examination, but a lot would get the needle. But many, many men would not take a needle. They're afraid of a needle. You bring the needle out, they start to sweat. I mean, women don't do that, but these big guys would start to sweat. The other point, Dr. Coleman, is that we have these university programs, academic programs, where after the task force recommendation, there was a lot of no screening. In my own academic program at Harvard, a lot of the attending doctors in my department stopped screening. Many of them didn't screen to begin with, but this is just another piece to stop them from screening altogether. And I was sort of probably the one or two or three people out of 70 docs in the internal medicine group that routinely screen men, especially high-risk men, for prostate cancer. So we've got some hurdles and some barriers still to deal with here. I'm going to open this up for questions. I know you guys have some questions for these wonderful presentations. And come to the mic.
Dr. Rayford, I found it very interesting. You made the difference in geographical distinctions in the profiles. Certainly there was probably environmental and social factors that contributed to that. But were you able to identify what those were?
Very good question. So we're very early in that study. Those results are probably less than 3 or 4 months old. So we are now going back to a couple of things. One, we're trying to expand upon this network. We're trying to create a network of urologists in many of those various cities where we can really study those factors, those social determinant factors, as well as the degree of racial intermix, as well as the knowledge, attitudes, and beliefs about men who undergo screening in prostate cancer early detection. So we're working on
This
it.
is a new study.
Yes.
Yeah. Thank you.
Next question? I have one. You talked about this, stratification for men with prostate cancer. How often is it that when, say, one of my patients who has a PSA that's gone up to 10 and he gets referred to, say, your department, urology, are all of those things presented as an option? Because a lot of guys ask about that, but it's a tough time sometimes finding the urologists who want to do 4 scores and some of the other things that should be done as part of this risk stratification for prostate cancers.
In my practice, yes, I offer a number of pre-diagnostic tests to help us identify those men who are at increased risk of having prostate cancer and those men who should undergo a biopsy. Early on in my career, I was very involved with looking at a number of different markers, the HK2 markers, complex PSA markers, percent-free PSA, and a number of other markers. Now, in my practice, we offer PC3. We offer HK4. We, of course, PSA, percent-free PSA. So, yes, in our practice, a number of pre-diagnostic markers are offered. Now, after the patient has been diagnosed with prostate cancer, then we do a number of genetic tests that really gives us much more information than just relying on what the pathologist sees under the microscope. So in all of my patients, they undergo genetic tests to further stratify their risk.
And that's done as a matter of routine with your patients?
That's
because
routine with my patients.
Okay. Because I think that's a great thing to do. Dr. Coleman, any comments on that?
Yes, thank you. So I would say pretty much the same in our practice, but a couple things. I think when men do come in after they have gone through the PSA testing and the DRE, the screening, we try to have sometimes it's hard to bombard people with so much information at times. And I was just researching, there are a couple of web sites that patients can go to prior to coming into their office visit to sort of kind of prepare themselves, to educate themselves about what is the prostate, where is the prostate, and what actually may be done. Now, one of the barriers I found when I looked at one of the websites myself is, well, one thing, being able to have a computer to be able to go on the website. Now, of course, libraries have computers and access and things like that. And also the education level to be able to complete the questions that are asked on the website in terms of knowing about prostate cancer or where the prostate is and what to expect when you're going to see your urologist for the first time to discuss this. The second issue, which is interesting, is I find that some of the men have a fear of, okay, if I am diagnosed with prostate cancer, am I going to lose my erections? And I'm always thinking like, well, do you want to be 6 feet up or 6 feet under? But I know I'm a comedian at heart. But this is also a very, I think, important point. They're not maybe don't know so much about in terms of urinary incontinence after prostate surgery or radiation or whatever, but they are concerned about their sexual health. And this also is a point that also the women, their partner, is maybe concerned about also. And so sometimes I may have this discussion, even a little bit of the discussion even before they even have the biopsy, because for some people, what's the sense of doing a biopsy if you're not going to proceed with the rest if you do happen to have cancer? But I think it does give patients some information to talk about to what's the point to proceed with the biopsy if you are found to have an elevated PSA and or abnormal DRE, because keep in mind that not all prostate cancers have elevated PSAs. There's some of them, about 10%, that have abnormal prostate exams that may have a normal PSA. So I think that's an important point to bring up with them too.
Sir?
Thank you very much for this great opportunity and great information sharing. I'm 57 years old. I was diagnosed with prostate cancer when I was 39, had a recurrence when I was 44, but everything is okay and fine now. What I wanted to know was how do people who have been out of the, it's been a while since I obviously had my prostate cancer, how do we become part of the long-term research protocol so that, you know, indeed whatever happened with me, I could be I could be helpful with regard to research going forward. And second, I just wanted to say that after I had prostate cancer, for 10 years I volunteered with Man to Man. It's a part of the American Cancer Society, in which we go to individuals who just recently had surgery with prostate cancer. We kind of help them through the process. But listening to you, doctor, I think a good thing is how do we get before that? Because I was fortunate, I had a very great wife and very supportive of me during the whole process, but a lot of men don't have that. And I think what I'm listening to you here is how do we deal with, okay, you've been diagnosed with prostate cancer, you are bombarded with a lot of information, how do we do that? So the two questions are, how do men who've had prostate cancer, like me, be able to participate in the clinical trials? And number two, I mean, and this is a larger question, I guess, how do we deal with those men who have just been diagnosed so that we could help them deal with the labyrinth and the maze and the emotions and the partners that come with that diagnosis?
Yeah, great question.
Yeah, those are great questions. You probably talked a little bit about the clinical trials yesterday, but I think a lot of it has to come with awareness with your physician. Sometimes a lot of physicians and primary care doctors are not aware themselves of clinical trials and putting patients in clinical trials early. I mean, a lot of times we go clinical trials when patients are at more advanced disease. We run out of our armamentarium of things that we may use to treat them, and then we look for a clinical trial. But they're actually, you know, this is something I think a discussion should be had initially with patients with respect to that. And then your second question is that I think after being diagnosed, and I mean, you do need to have a support group. And I think that's another very important part, and you were lucky. I mean, at 39, we wouldn't even have been screening you until you were 40. But thank God. But yeah, I mean, did you have a strong? I don't want to be too personal, but you have a strong. Since you mentioned, did you have a strong family history, or?
No, what
you
happened
just?
is I was running. Back then, I know I may not look it now, but I was training for marathons.
Okay.
And as part of my birthday, I would do a full physical exam, and thank God until these people married the right woman. So my wife said, you know, you're 39. I read that prostate cancer comes more earlier and it's more aggressive in black men. Why don't you get it done? And I heard one of the physicians here saying, well, you know, my general practitioner, oh, you don't have to worry about it. You're 39. Don't worry about it. Don't worry. But you know, she said, you know, no, get it done, get it done, get it done. Had the DRE, was slightly enlarged, and waited a few, like 2 weeks later, had the PSA, and the PSA was elevated. Waited 3 months, the PSA after that was elevated, and had the biopsy, and it ended up being positive. So that was the only reason, was because, you know, my late wife is pushing, you know, got to get it done. So that's why no incidence of prostate cancer, just reading information and being smart about what's good to take care of your physical body.
That's great.
You know, let me just add to one thing that that was said earlier, and that is we've conducted a survey of physicians, and we asked them what's their major reason for not participating in clinical trials. The number one reason was they're not aware of the clinical trials themselves. So how can we recommend clinical trials to our patients if we're not aware of it ourselves? So we have to do a much better job, Tom, and I know we're trying to work with Tom on educating physicians about what clinical trials are available, and particularly what may be available to their patients, and then they in return can make their patients more aware of the clinical trials.
Yeah, and one point before you come up, the other thing to add to with the early detection is that even though, you know, most of the time we may find a patient their PSA is normal, but within our database we have men that are that come back, and so we can also look at their PSA velocity and see if there's an increase in it over time. And so they may have come in with a normal PSA last year, and all of a sudden it's doubled or gone up, or maybe in their DRE rectal exam has not increased that much. Then that might give me a little bit more heightened awareness. So I think it's also important for men. I mean, they're not, most of them are not going to have prostate cancer. But it's the education, it's the information, it's the baseline number that they get that then they can, you know, if they're repeat returners or if not, with their primary care doctor, they got information they can give their primary care doctor, and then they, you know, can go on to have a healthy life, healthy prostate life.
Thank you.
Hi, sorry, Denise Gooch, Radiation Oncology, and I wanted to thank both of you for being here. In particular, Dr. Coleman, I appreciated your comments about men and their perceptions of being diagnosed and treated for prostate cancer, because as you said, by the time a man comes to see me, of course, they see the urologist first. One thing I've noticed with my discussion about the possible side effects, as you said, as physicians, we always think they're worried about the bladder irritation or rectal irritation, but the main question I do get is the risk of erectile dysfunction. As a matter of fact, I participated in a health fair at one of the mega churches, anybody, First Baptist Church of Glenarden, and really, you probably know Mr. Battle. He and I are actually going to be working together because we just received a grant from LabCorp to screen 500 men for prostate cancer. That just came through last week. And but one thing that we noticed, I was actually in the audience just listening to his presentation. He was doing a wonderful job. But then it just so happened one of my patients who was actually being treated in my clinic started talking about his diagnosis and his treatment. And then someone that was asking me about it, and I'm trying to explain all the other side effects, and one of the guys, he said, no, I'm talking about the other side effects. And I go, oh, that's what you really want to know. And as you said, then it's a different discussion, and we talked about other things about ways to treat and incidents. And the more I was actually in Atlanta just this past weekend speaking at blueflowers.org, you probably know. A lot of those people will be here today and this evening. And one of the things I noticed that when I was talking about the diagnosis, but the main questions I was getting from the audience were the side effects. That's what, you're giving all this information, we're saying you need to be screened, but as you said, being screened and being even diagnosed and undergoing the biopsy, if they're not willing to come in to get treated because they're worried about the risk of erectile dysfunction, which is what has been indirectly what I've noticed, it makes me think that's the disconnect. We think they're worried about the bladder and rectal irritation, but my experience has been, as you just mentioned, that they're more worried about the risk of erectile dysfunction. So I actually have a presentation where I actually address all of that and talk about the medications, Cialis, because that's something else. Everybody says, so what's the difference? What is Viagra, Cialis, and Levitra? I actually have 4 slides and actually goes through and the side effects and duration of action and blah, blah, blah. And I noticed that's what most of the men wanted to hear about. And I go, oh, I'm talking about all these other things. Nobody cared about any of that. I just wanted to thank you because that was actually my experience too. And to let everyone know that hopefully you'll hear about us. But you probably know Mr. Battle. He'll probably tell you we're working together and so we're going to be screening men in the community.
Great,
he probably
beautiful.
told you we got the grant.
No.
He didn't tell you yet. We just got it last week from LabCorp.
Beautiful.
That's great.
All right. Next.
Yeah, I'm Kwasi. I'm a city planner here in Fairfax County, and we have an advocacy group. It's just a general question. The Department of Defense has given out a huge grant for male prostate cancer study in African countries, in Ghana, South Africa, Kenya. And our group over here asks NIH to use some of the Howard University Hospital, the experts in some of the black hospitals around here, and we realized that they've given it to Harvard. And also we have a number of these doctors in Harvard who've been running around Ghana, South Africa, Kenya, and others. And I just wanted to find out whether you are aware of it or whether there was any effort made to contact some of the medical colleges of the HBCUs, to get involved, because what we thought was there would be much more of a better connection, to see if there's any relation between the African American prostate cancer research and then African male prostate cancer research. But all that we see now is just a group of guys from who have been flying to Ghana to do the study. I just want to find out whether you are aware of any of them.
That's an interesting question on the communication issue. I'm going to ask Clinton, do we have that information at Howard yet?
I'm sorry, I didn't hear.
About a grant from the Department of Defense and prostate cancer in people from Africa versus African American descent.
No, I have not.
Yeah, so that's really, you bring up an important point with communication. So we have to.
They got a grant, I think, late last year, and it's a very huge grant. but there is no African American medical practitioner involved. And that was what we over here actually appealed to NIH because they were the conduit and they gave it to Harvard. And it's been a concern to some of us, so that's why I wanted to just find out.
Yeah,
It's
thank
something
you.
You might want to check out.
Yeah, we definitely need to check that out, yeah.
So you said they gave it to Harvard?
Yeah, they gave it to Harvard. Enchant Medical.
Yeah, so that's the School of Public Health. I'm an alum, yeah. So,
So they have it's in millions of dollars.
Thank you for that information.
Good morning. I was excited to hear about the prospect of bringing up the topic at family reunions, and I know I'm going to do that. No matter how nervous I feel, I'm going to bring the topic up. So thank you for very much for that. I was excited about your mobile unit, which is something that actually goes into the community.
Right.
Do you know of any other mobile units in this area or any other places? And how can we contact you to get your information and take it to other places? Because that's the answer. Go where the people are. So thank you.
Oh, you're welcome. No, there aren't any other mobile units in this area. Do you have a mobile unit where you are?
Memphis has at least 2 or 3 mobile units affiliated with the hospitals.
Oh, that's great. But yeah, I think taking to the people, that's what we found from our initial abstracts from that first publication from our MNTAKE 10 research, that taking to the people is where to go. And so, yes, I'll be happy to speak with you later and give you some information about that.
Hello, Clinton Burnside with Howard University as well, and I work very closely with Dr. Coleman, so thank you both very much for your presentation. I actually have one comment and actually a question as well. So the comment actually is in reference to just the education of the men. We actually partner with Finn now, and we do a support group, and I work very hard, just presenting different topics to the men, because it's actually a men's health group. But the focus has been on prostate cancer. And one of our best groups happened to be last week when we talked about sexual dysfunction in men. I mean, it was a very lively group. So that is very important to the men. But just in terms of just the education period, I think every opportunity we can get, we should definitely push it. Because, you hear a lot about, from men saying, oh, well, I don't know anything about prostate cancer or screening and even the treatments and things like that. But I'm actually out in the community, and that's the biggest difference. You have to go out to them and not necessarily wait for them to come to you. So the question is, we're actually screening here at the convention center, and I had a guy to come up to me yesterday and ask about a procedure that I wasn't familiar with. So I just wanted to ask if one of you had any insight. He talked about a procedure called Resume, and I'm not familiar with it. And what he described is something, they will insert something into his penis, and it'll go up into his prostate to kind of expand his urethra because he has a BPH. So I didn't know anything about it, so he was asking. So I just wanted to know if when he comes back to me today, how should I address that? Thank you.
Yeah, that, as he was intimating, that's a procedure for the treatment of an enlarged prostate. It's a thermal-based treatment. I don't do it myself. I don't have any experience with it, but it is one of the newer modalities that's used to treat men with obstructive voiding symptoms.
Right, but I think it's important. I don't do Resume either, but we have an opportunity to talk to men about other issues besides prostate cancer. And more common than prostate cancer are enlarged prostate and symptoms, signs and symptoms from enlarged prostate. So I think it's a great opportunity to take time to educate patients and their family members about a lot of different subjects. And I will submit that last meeting that we had, and thanks again for Finn for the support group, with erectile dysfunction, I was actually able to bring out different treatment options for erectile dysfunction. We had obviously the medications there, we had pictures of the vacuum erectile device, the pump, the injections, the needles. So people could actually visually touch and see these things. And I think that was so important. And that was a way to actually kind of break the ice sometimes in terms of getting on to talk about treatment options in prostate cancer. So.
But before the next question, I just want to make a comment about the mobile treatment program. So for 10 years, we had a program in Boston based at Dana-Farber Cancer Institute. I actually was the medical director of that program, and it ran until 3 years ago, 2013. And the reason for the demise was the Preventative Services Task Force recommendations about the lack of screening. And with that, the leadership decided to stop the program. So the task force has had impacts in a lot of different places in this country. Yes, sir.
Yes, my name is Brady Wilkerson with Team Prostate, and I happened to attend one of the events that Clinton had done over at.
So speak up. Yeah, Mike.
Hello? Hello? Can you hear me? Okay.
You could get up, probably.
I had an opportunity to attend one of the events that Clinton had participated in within the community, and on the table was a display that made a lot of difference to me, which was simply all the various stages of a normal prostate to one with all various kinds of problems. In terms of screening, one of the things that I like to emphasize is every man over the age of 50 should have a relationship with a urologist. Now, I know that may or may not necessarily gel with the medical profession in regards to their relationships with their patients, but I wanted to get some feedback in terms of screening, how important you think it is to have men over the age of 50 to have that relationship. Not necessarily referred by their doctor, just simply even requested by you to your doctor. Your thoughts?
My initial thought is men over 40 should have a relationship with a physician. Now, one of the things that research has shown us is that, unfortunately, most or many African American men don't have a relationship with physicians, and most of their care, acute care, is obtained in the emergency room setting, and which is unfortunate because there's really no continuity of care in that setting. So all men, African American men, all African American men should begin to have a relationship with a physician beginning at the age of 40. And once, if they go on to develop urological problems, then they should see a urologist.
I mean, looking at our data, I said about 42% had a primary care, but 60% didn't have a primary care doctor. And what I have found is that for most women, I mean, they establish a relationship with a physician at menarche, at menses. They start seeing a physician, OBGYN usually, right? And so they're women, girls, women as they go, are more socialized into having to see a doctor. Men, on the other hand, probably don't really come in into something's burning, itching, or or not working properly, right? Yeah. And then they're more likely to come in or go to the emergency room first, and then come in. So I think you're right that it would be to some degree have a relationship with a physician, and if you need to with a urologist, because let's face it, sometimes the physicians in primary care, blood pressure, diabetes, cholesterol, things like that, we might have a little bit more time, and we have more insight into talking to them about their urological issues.
So we have time for one more question, but the point that the guy should have a urologist as a specialist, is that the point that I was?
Yes.
Okay, yeah. I don't get enough urologists to cover all the guys. But if there were, that is something to consider. But as a primary care doc, we do most of the screening, and primary care docs actually do most of the prostate, most of the cancer screening period. So it'd be tough to sort of say that he needs to see a urologist. But if he's got a urologic issue that cannot be managed by the generalist, then the person should see a urologist. I think that's a good point. Doctor?
Good morning. Thank you both for coming, really. My name is Dr. Gary Taylor. I had one of the sessions yesterday. Okay, I'll try harder. How's that? Can you hear me?
Yeah.
Oh, good. Okay. Dr. Davis, I was concerned about, I just wanted you to elaborate a little bit more. When you opened up, you said that this is a very curable disease. And it kind of struck me. I've kind of heard that before. I don't really see my disease as being curable. Just to give you some history, I was really struck by your story because at 58, I did the same thing. I had been running marathons. I was healthy, on no medications whatsoever. I got ready to run another marathon. I hadn't done it in 5 years, so I decided to get a checkup, and my PSA was elevated. And it really wasn't elevated that much. it still was, it was 4.8. I thought I was pretty much okay since it was below 10, since that's what most people told me. But on my biopsy, I had a Gleason score of 8. And quite frankly, I was devastated, to be honest with you. And even now, 2 years later, I'm looking at getting PSA tests checked, every 6 months, 4 months for the rest of my life. So I don't see this as a curable disease. It's certainly treatable, and I hope it's treatable for a long time. But I was wondering if you could elaborate, because I've heard that before, and I don't understand that. It certainly doesn't seem like it's curable to me at this point.
Sure. Well, that's based upon, one, the premise that if we detect cancer in the very early stage of the disease, before it has gotten outside of the prostate and delivered to that prostate definitive treatment options, either radical removal or radiation or some form of thermal therapy, then those forms of treatment are curative. Now, the challenge comes in is, one, if the cancer has already spread outside the prostate, and a person selects an option that is not curative. We are beginning to understand now that there are certain forms of prostate cancer that do not respond to radiation, and there are certain forms of cancer that do not respond to certain forms of chemotherapy. And it's very important to understand those forms of cancer at the time of diagnosis. That's a lot of my research now is aimed toward further stratifying those men and really assessing their risk at the time of diagnosis, so that I can give them, or we can have a very, very meaningful discussion of what forms of treatment that are more likely to lead to cure for you. Many of the patients that I see have aggressive disease, and from the outset, I tell them that our best chances of cure will be multiple forms of treatment. So we are moving from a salvage standpoint to more of an adjuvant standpoint. So in my men with aggressive disease, men young like you who have a Gleason 8, I tend to recommend a robotic surgery followed by adjuvant radiation, despite the fact of what their PSA may be 2 or 3 months later. Because recent research has demonstrated that if we give those patients radiation adjuvantly, adjuvant is defined as within 3 months of your initial treatment versus when you think the disease will come back, then there's an 80% improvement or risk reduction in metastasis and mortality. So it's curable. We just have to treat it early, and we have to treat it with the right thing.
Yeah, I would just mention one last comment, and then we'll have your question. We'll have your
No,
question.
we don't have any time for any more.
We have a question. I'm sorry. We can take it outside.
Yeah.
But I think
Sorry.
that just really brings home the main point here about prostate cancer screening. And for men, you can be healthy. I mean, you can be healthy and have prostate cancer. You don't know it. You can't feel it. You can't touch it. You can't smell it. You can't see it. So you need to come in, for men need to come in, and right now we're at age 40. There's sometimes outliers at 39. But come in at age 40 and get your prostate screening, your DRE done, because you can be very healthy and unfortunately have some concerns, things that need to be taken care of.
Thank you. We'd like to thank Dr. Rayford and Dr. Coleman. Wonderful presentation. Thank you. And Tom.
Let's give this panel another round of applause. I think they did a great job. I would like to point out one fact. When we started FIN in 2003, one of our major emphasis was on getting African American PSA screening levels up to those of white men. We had a presentation at our webcast last week, and what happened now is that PSA screening for black men is greater than it is for white men. And that's a real accomplishment. We had a setback with the task force where people stopped a lot of the mobile screening units. The primary care doctors were not doing screening unless you asked. So part of the things that we have to do is continue to be strong advocates in our communities for screening. And our position at FIN and our guideline is African American men should begin PSA screening at age 40. And so we strongly recommend that. The data is now showing that the task force made a misstep and the data, that the way they interpreted that data. So our challenge is to continue an aggressive screening approach. It saved lives. So thank you all. We have a presentation for Dr. Rafer. Okay, sorry. And Dr. Coleman. And we're going to take a picture right here, and we're going to move on to our next session. We'll get our photography. And Dr. Carter already has one. Come on in. Don't go. Good, thank you. Thank you again. And I know that, I want to get the Congressman. Everybody having a good time? That was a good session, wasn't it? Yeah. We have the congressman here on his phone. All right. As I pointed out when we started our session yesterday, at the U.S. Capitol Visitor Center, that our host for both these days is Congressman Greg Meeks out of New York. And we began this relationship 13 years ago. And Congressman Meeks is truly committed to our goal of eliminating the African American Prostate Cancer Disparities Summit. He demonstrates that every year through supporting us, not just here, but all of our advocacy efforts. He lends us his staff, and as I've said for many years, Congressman Gregory Meeks is out of New York, and I'm out of Boston, but Congressman Meeks is my congressman because he carries our message throughout the legislative community. And he works with us on a continuing basis, and we're excited and glad to have his support. It has been a lot. We would not have been here at the ALC for the 13 years that we have been here without his support. So I want you to join me in welcoming Congressman Gregory Meeks, our host for this session.
Thank you. 13 years. Doing the Lord's work. And you've been doing it longer than that. I just, So I'm honored to be here and honored to call Tom Farrington and Mrs. Farrington my friends. This is indeed God's work. And each year we come and hear a distinguished panel to talk and to give information. And what's important about it and why the 13 years is important, because sometimes we come and we do something for a year and we go back and there's no follow-up and we don't do it again and we lose things in the process. But with Tom's leadership, we've been persistent and consistent. And each year that we've come, we hear new and different information. We see where the progress has been made and gains have been attained. And we also learn what is necessary to do. For it is absolutely clear we've come a long ways in 13 years. But we still have a long ways to go. And as I've indicated, in those 13 years, there's been two gentlemen on my staff who had been diagnosed and treated and cured of prostate cancer. So I thank each and every one of you for being a part of FEN and spreading the word and getting people together. More African American men, thanks in no small degree to the awareness and insistence, particularly of the women in their lives, because the message has gotten out that they are more African American men that are now going to have physical examinations. There's been more research and treatment dollars being devoted to addressing the disparity that continues to happen in the United States of America as it pertains to prostate cancer. So what I believe that, and what I know what Tom Farrington believes, and I believe when the other speakers that you will hear from and some who you have heard from already, what it boils down to is three challenges that we still have. One is quickening the pace and widening the scope of research. The other is dramatically increasing the number of African American men 40 and older who regularly are tested. And the third is doing more to eliminate the disparity in treatment options given to African American men found to have prostate cancer. And it was brought to my attention, which I'll just talk about real quickly, and it might be mentioned here again, about two recent studies that underscore the problems and the tasks that lie ahead. One study which reviewed National Cancer Registry data on white men and black men aged 40 or older diagnosed with prostate cancer between 2004 and 2013, found that black men with the more aggressive types of prostate cancer were less likely than their white counterparts to receive the aggressive treatments that have been found to be most effective in enhancing survival rates. The study lead researcher made the following observation. Given the evidence suggesting a benefit for treatment in men diagnosed with intermediate and high-risk prostate cancer, our findings may explain to some degree the differences in survival odds between black and white men diagnosed with prostate cancer. It also looks at that the black men studied were more likely to be low income and uninsured or covered by Medicaid. And although both white men and black men in the study experienced a slight increase in receiving aggressive treatment, there was a 10-point gap in favor of white men in the proportion of men who received aggressive treatment. In addition, just 1% of the 356 facilities under review were more likely to prescribe aggressive treatment for black men than white men. And on top of all of this, in the South and the Southeast United States, including Alabama, Arkansas, Florida, Georgia, Louisiana, Maryland, Mississippi, Missouri, North Carolina, South Carolina, Tennessee, Texas, and Virginia, states in which African Americans range from 10% to nearly 40% of the population, and we know that from the Democratic primaries because you can't go through there, if you're going to win without them black folks coming out to vote for you. But white men were 69% more likely to receive aggressive treatment than black men. Also indicates why the politics in the region ties in and why that's so important. Another survey, this time of more than 1,100 African American men and white men with prostate cancer in North Carolina by researchers at the University of North Carolina Lineberger Comprehensive Cancer Center, suggests that economic factors and not having health care insurance that covers prostate exams and treatment may contribute to the African American disparity. I bring that up because it is part of the political debate of which we're having today in Washington, D.C. We have until September the 30th or about the Affordable Care Act. So there's a big push that you're reading now in the newspapers and others where you see the senators are trying to push of whether or not they have the votes to repeal the Affordable Care Act. And if you look at the messaging of what we're talking about here, you're talking about taking away and making substantial difference in pre-existing disease, and as well as getting treatment and testing early on. Lives are literally at stake in this fight. It can change the positive directions of which we have been moving. So when we, and I bring that up because we don't want to just talk about the Affordable Care Act and health care in a vacuum. It has a direct connection to what we've been fighting and trying to make sure that we accomplish over the last 13 years. And so we need voices throughout America to stand up, to talk about as this new bill that the Senate is putting up to take things and send it back to the state. I asked the question of this. They say, take the federal government out of health care. But then we should go back and ask every senior, do they want to get rid of Medicare? Because Medicare is federal health care. So it's serious times and serious business of which we have to deal with in this Congress and with this administration. And it also goes to show that elections do indeed have consequences. So when we leave this Congressional Black Caucus Foundation yearly event, we must redouble our efforts and not take anything for granted to make sure that health care is a right for all and not a privilege for a few. So with that, as I conclude, I want to make one special presentation. Because for me, 13 is a lucky number. 13 is a special number. 13 means that there's consistency and persistency. And we have a special award that I want to present to Tom Farrington. We voted and we talked and we said that there's certain people, because some go to the dinner, we don't, and certain people get awards and recognized, but there are heroes and sheroes that are on the battlefield every day. They're not in the national spotlight, though I believe they should be. And we end up taking them for granted. And we take Tom's leadership, I know those of you in this room do not, for granted, and I want to make sure he knows that we really appreciate all of the work, the time, and the sacrifice that you make on a daily basis, and on behalf of the lives that you have saved, because you have literally saved people's lives. So this is the Congressional Black Caucus Foundation Leadership Award presented to the Honorable Thomas A. Farrington for all of your work and dedication to saving black men. Thank you and enjoy the weekend.
Thank you, Congressman Mase. And I want to say that I accept this award with gratitude on behalf, number one, of my wife, who's been with me for all these years. Please stand. And also on behalf of the members of our FIN network who makes our work possible. So could the network members stand again, please? Give them a round of applause. We all deserve this. Thank you. Thank you, Congressman. This is it's not only an honor, but this is a pretty award as well. So I'm going to display this proudly. Thank you. Thank you. We have another session, and I do want to say that we have the time because our program is scheduled to end at noontime, but we have an extra hour, I'm told. So we are going to have time to do all of the business that we had planned to do today with that extra time. So what I'd like to do now is to move to our next session, and I want to introduce the moderator of that session. And I don't have my program here, but I think I know who it is. For a number of years, we have really focused our community outreach, working with churches, as I mentioned before. So our faith-based initiatives are so critical to reaching out to educate men about the importance of screening, now to educate men about the importance of participating in clinical trials, to getting information out to them about their treatment options. And through our initiative, we've been doing that in an organized way since 2009. Prior to that, we certainly did it since our founding in 2003. So we have, I have recently brought on someone that I've known for quite a number of years, Adrian Backus, and to kind of head up that effort nationwide for us. Adrian is a young man that finished school at UNC in North Carolina, and he went on to receive his law degree here at Howard University, and he then went on to the Princeton Theological Seminary to receive his master's in divinity. And after he finished his master's in divinity there, they saw the genius in his working skills. So he ended up working there for, I think, about 13 years as a vice president at the Princeton Theological Seminary. He recently has come back to Maryland where his family resides as adult children. And so we were able to, I was able to talk him into joining us and doing some work. And I had a little bit sway over him, simply because he happens to be my brother-in-law. And not only my brother-in-law, he's kind of like a third son because he kind of grew up with my sons. And so we had talked about him joining us and doing some work, and we finally made it happen. So I think with his background in law and his background working with churches, he's also pastored So I think he's the right man for this job, to make sure that we move our efforts with the faith-based community nationwide to another level. So I want you to join me in welcoming, I can never call him Reverend Adrian Backus, but I guess I should in some cases. But I want you to join me in welcoming Adrian Backus as our next, the moderator of our next session. So, thank you.
Good morning. I don't want to hold things up. I'm so happy to be here and so happy to be with Finn. I have known, as Thomas said, I know he was going to let all the secrets out. I've known he and Juarez Farrington for over 50 years of my life. And I went up when I was 13. And what I do want to say is that when Tom say go left, in some cases when I go right, I have to be careful because Juarez is behind me, so that means go left. They have been life givers in many ways than one in terms of people. So being asked to have the task of working with what I think is something very critical is very important. At Princeton Theological Seminary back in the late 90s, I looked at issues that we in the black community in the area of theology need to focus on, and we don't. And one of those areas was health. I did a major study on theology and mental health. That was very critical. But what I find, Eric Lincoln showed that there were, in the areas of ministries, or whatever we do in communal ministry, is that in the areas of health, and some of the other areas, I did a paper on the economics of religion and its effect on Afrocentric people. Very critical papers of how we're working commercially that many churches are trying to get a hold of. We're doing less than 10% of our ministries and community-based ministries and organizations in these areas of health and economics. And these are pieces that are very critical for us. So I'm glad to see that there are organizations that are turning these things around because they impact us and our families. And certainly this is one of them. So I am very happy to say that we are being very, very aggressive, progressive, in moving things forward in terms of touching the lives of people. So to that end, I'd like to say that this session will focus on faith-based education and awareness initiatives aimed at mobilizing African-American communities in the fight against prostate cancer. We will review and highlight the FIN 2017 educational symposiums, the Father's Day rally, with a discussion of FIN's plans for the future. And we're even looking at entertainment and education. We have to reach people. Now, I gotta say this, I'm conservative, but we talked about a lot of nice physical, medical information, seriously critical yesterday and today. That's the physical health side of it. There's a mental health side of it that we need to understand too, because it's true. When you go to these churches and you talk with people, we have to break the silence that's happening with the men and our communities, our women, and our caretakers. That's something that's very, very critical. So it's the mental, and then they're very serious about the spiritual act. I will tell people, last night I was with a man that just had surgery, and he said, I want you to be with me, Pastor. Before I can pray with you, sir, I have to touch your life to find out, what do you have to say to me about you? So we have to be very human about what we're doing. So the psychology and the way that we work in our communities is very critical. You will be hearing that. We had a session at Finn on psychology the other day. Didn't we have that? And the medical. We cannot separate the two. So I want to introduce these people because I'll get too happy. But anyway, I was going to talk about my tie. I wasn't going to wear blue or black in here today because this is the critical part. If we can't get the voices, we have a problem. We can have all the answers in the medical piece, but if we can't deliver, it's no good. I was telling a preacher this morning, sir, you can have a great sermon, but if you can't deliver, the people won't be touched. And so this is eye-breaking, tear-wrenching kind of stuff that we're talking about. How good God is? James is my neighbor. He didn't know I was going to be here. He told me he had cancer. The gentleman that's 39, that's a giving gift. So what I'm saying is that you will not sit silent on me. You will not sit silent on these people. I wore this tie. This is Bocolon Fini. Mud dye. It's critical. I didn't eat yesterday, so I can get in this suit. And I'm telling you now, this is about life. It's not dead in here. So let me get finished. So I want to hear this session. I said, we got the best session. We're going to get a prize. All the rest of them are great, but we make it work. We make it happen. That's why you are here. So here we go. Let me get my glasses real quick. And before I get run out of here by Tom and Juarez. Let's go with it. Okay, so the first person that we will have during this session, I'm going to give his bio, is Reverend Blaine J. Newberry. Reverend Newberry is a native of Philadelphia, married to the former Kathy Lee Hill. He was educated in the Philadelphia parochial school system. Reverend Newberry is a member of the Enon Tabernacle Baptist Church in Philadelphia, and he's been a member since January 2006. But he's been employed full-time as associate pastor of fellowship. He currently has pastoral oversight of ministries in special projects of this 15,000-member church. Reverend Newberry attended Johnson C. Smith University in Charlotte, North Carolina, earning a BA degree in sociology and social work. He also is doing an MS degree, or did an MS degree in administration of justice at Shippensburg University in Pennsylvania. And Reverend Newberry is also matriculating at Palmer Theological Seminary in Philadelphia, where he's getting a Master's of Divinity degree. Reverend Newberry has guided the development of youth in Philadelphia as a juvenile probation officer, a gang prevention officer, and recreation leader. In March 1988 through December 2005, Reverend Newberry was employed as a federal probation and parole agent for the Third Circuit of the United States District Court in Eastern Pennsylvania and the Department of Justice. And he's working as a liaison to the United States Bureau of Prisons for reentry programs. And we just want to give a hand for Reverend Newberry as he will come forward. Our next panelist is Ms. Lillian Alston. Ms. Lillian Alston is a senior project engineer of engineering and information technology for the United States EPA in Research Triangle Park in North Carolina. Ms. Alston is a member of the Mitchell Chapel AME Zion Church in Pittsboro, North Carolina, and has been active with Finn since 2003. There are exceptions, and she's one of our Finn ambassadors in her community, and she's here with her sister. She's an ambassador too. You can't split the two up, I'm gonna tell you, I already found out. She was instrumental in helping to form the Orange and Chatham African American Prostate Cancer Support Group, which was the first support group in their community to address the needs of African American men who suffer the highest risk and death rates for prostate cancer. She has successfully led prostate cancer education efforts with her church, other AME Zion and Baptist churches, support groups, and rallies at her university, their town, and within their AME Zion district. Ms. Alston holds a BA degree, a BSAE degree, bachelor's degree in architectural engineering, and a master's degree in computer science from North Carolina Agricultural and Technical State University in Greensboro, North Carolina. Ms. Alston is a registered professional engineer. Give her a hand as she comes forward. Our next panelist, I had the fortunate opportunity to see them at work down in Richmond. And you know, one of the great things about this is I get a chance to hear a lot of men saying some good work. And I done heard everything from the Mighty Clouds of Joy to Smokey Robinson over the last 6 or 7 months I've been traveling around listening to these people. I told Tom we're gonna have to get a Finn choir and show y'all what we're seeing out here. So Deacon Donald Chambers is our next guest. He is the CEO of Express Movers, LLC, a local moving company servicing Richmond, Charlottesville, and Tidewater areas. Deacon Chambers also serves as deacon at the St. Paul Baptist Church, where he has been a member for more than 20 years. He is an active leader with the Barnabas Counseling Ministry, where he has led a men's support group for more than 10 years. He is a faithful believer in the principles of brothers supporting each other. Over the years, he has encountered countless men of all ages and backgrounds who have come through this 8-week support group program in an effort to better themselves emotionally and spiritually. Deacon Chambers is a resident of Sandstone, Virginia. He's married to the love of his life, Glennis Daniel Chambers, and they are proud parents of 2 adult sons. Let's welcome our deacon as he comes forward. And we have a special guest. Now, his coat outshadows my tie. And so you know he's got to be in the production business when this man comes up, Mr. Garrett Davis. Let me tell you about him. This is what we're talking about with Tom in our organization, is how we reach people in so many venues and mediums. We have to be as creative as whatever the streets would do to get to us. So we're doing this, and we're very happy to have Mr. Davis and others with him. Mr. Garrett Davis is the head of G. Davis Productions, which started off as Rima Theater Group Ministries in Rayford, North Carolina, where Garrett penned his first stage production entitled Lord, Why Me? After his first national tour and the success of If Loving You Is Wrong that featured Freddie Jackson, the name was changed to G. Davis Productions, and the slogan was established, bringing real-life situations to stage. The relationships that G. Davis Productions has established over the years with the National Alzheimer's Association, U.S. Against Alzheimer's, Wake Forest Baptist Medical Center, the Maya Angelou Center on Health Equity, the American Diabetes Association, and the AARP has created a unique partnership that focuses on raising the awareness of various diseases and caregivers through award-winning projects and theatrical productions. Let's give a great hand for Mr. Davis, who will come up. And I'll give you we're gonna do a quick also historical piece on where we are and where we come from, just giving you some data points. And I have my friend there, we ready, we can go forward now that I've done that. I'm just gonna give you some information on what we've done. This is what Fin-based initiatives, faith-based initiatives look like here. We have the Father's Day rally that some of them will speak about, where it was launched in 2009 from our historical point, and there are hundreds of churches across the nation that incorporate the whole issue of prostate health in prayer and other things during their service for Father's Day. The educational symposiums, where we have listed at least 20 in 2017 that started in 2013. This is the service that we will hear from the Richmond Church in terms of how we bring the professionals. What you've seen here over the last 2 days with the medical professionals. I travel with these doctors. I feel good because if anything goes wrong, I got some help other than Jesus waiting for me. And but we travel and they make the same presentations that you've seen, and the impact of that has been great. Because someone asked yesterday, well, how do you get this out? That's how we are doing it, with these professionals traveling around from place to place, and these churches and other organizations have been hosting us, bringing in people to receive us. The last one is Partnerships for Education Support and Outreach, PESO. That started in 2016. You'll be hearing that today from Reverend Newberry, and that's where churches locate or connect or network with the broadcast of Finn's monthly webcasts as educational programs. Those are very, very critical. And there's a church here that has done very, very well in making it happen. So we have the best up here. We got all of them the best now, but we have them here because what you want to hear is, and we want your feedback as well, is they tell us about how well we're doing. You know why? Because those voices are telling us whether we've received them or not. And so the issue for us then is, how do we tweak it? How do we make it better? How do we make it stronger? How can we create the reach even more, like what we heard with the mobile unit? So now I'd like to just start our program off with you, Reverend Newberry, and I'm going to sit down there and I'll watch the time.
Good morning, everyone. Good morning. That's good. Well, I'm certainly glad that Reverend Adrian did his thing. I won't be like him, but we thank God for him, and certainly want to thank God for Brother Thomas Farrington and all that he does for Finn. I am a Black Baptist preacher, so I don't speak unless I mention the scripture. So I'm going to begin with one, and I'm going to end with one. It all makes sense. We'll pull it together. First of all, when we speak of prostate cancer, the first thing I would think about, especially it involves African American men, that when they hear the phone call or they get the notice in the doctor's office, they are generally, most cases, by themselves or with their wife or significant other. And when they hear that they have prostate cancer, their mind goes into what I call just simply a tizzy, but the one thing for a Christian man is to remember that God is my refuge and strength, a very present help in a time of trouble. What you won't see in my bio, thank God for it, is that I'm also a prostate cancer survivor. In December, it will be 6 years that all of my numbers have been, amen. All of my numbers have been zero since then. Unfortunately, most of my friends who have experienced it have had reoccurrences. And I never asked God why I haven't. He says, well, you have to be on the battlefield of passion to help other men. At the age of 39 was when I started having symptoms. In other words, enlarged prostate, unusual periods of urinating, etc. So I became a study project at the University of Penn Hospital. I once had a cystoscopy. Now watch this, without, believe me, any prepping or anything. So my urologist asked, well, how is it that you would not, want to have any prepping or anything? I said, well, let me just see how it feels. Well, that was the first one, but the second one, trust me, I had to work on it. However, we want to talk about Enon Tabernacle under the very capable and honorable leadership of Reverend Dr. Allen E. Waller, who is our senior pastor. And also one of my brothers, and he's looking online as well, Reverend Leroy Miles, who is a co-partner as we work toward eradicating this dreadful disease of African American men, but more so bringing awareness and education right to their seat. They have no excuse not to know because Enon Tabernacle has taken a stand regarding the eradication. What you have before you is a summary of what we deem and call a project called Know Your Numbers. We've been involved with it since 2011. And what we decided to do under the leadership of Pastor Waller, March Madness is 6 months away. That's the NCAA basketball tournament. And we said we would do something during March Madness where we can pull African American men and Afro-Caribbean men together under one place. And what we do, we literally call this place the Man Cave. We don't have no service on this particular Saturday. We have several services over the weekend. So in 2011, we actually had over 1,200 men who came to our church, 13-hour event. At that event, we were able to test over 800 men with the PSA and DRE, and you'll see the numbers that are there for your review. But what was more important, we said, how is it that we can get men not to use the excuse? Well, we know that men on Saturdays like to go to the barber shop. So we have community barbers who come in and they cut their hair. The brothers don't have to pay for the haircut, but we do ask that you give them a tip. We also have games, board games, various card games, video games, and other types of competition. We train men to begin a process of how you ride a bike, et cetera. We begin the process of teaching them proper exercising and healthy eating and nutrition and so forth. However, what's significant for us, what you won't see, is in 2011, there was an issue in Men's Health magazine stated that Philadelphia is one of the unhealthiest cities for men, ranking the city of brotherly love 99 out of 100 cities that were surveyed. Among the racial groups that comprise the population, black men ranked the highest. And that's when our beloved pastor, Reverend Dr. Alan E. Wallace, said we've got to do something about it, and therefore the inception of Know Your Numbers. However, what's significant is this, that if you want to have a significant health event or awareness and education, there has to be a partnering of the medical community with the faith community. In other words, our job as preachers is to speak truth to power. And therefore, if work isn't done or we don't think enough is being done, what we're saying is, as a church, that we're not afraid to go to those who can deliver and help us to deliver to our people. So what we did, we embarked upon a major project with a hospital in 2011 that I care not to name at this particular time, but we're working on renewing that relationship. And what we said was that we would bring the hospital to the church. In other words, we shut the church down and turn the church into a hospital, utilizing every room in the hospital for various screenings, and then also to have the doctors come out and to speak relative to those medical challenges that affect us. Now, we know there's hypertension, there's diabetes, we know that there are challenges with other cancers, etc. So therefore, we address all of that. But what's even more significant is when a hospital or medical facility realizes that faith and cure and healing work hand in hand. And therefore, what we embarked upon has been a major event that has gone on for the last 6 years. So we say to ourselves, how else is it that we can move forward? So what we've done, we literally have relationships with every hospital in Philadelphia and every cancer center in Philadelphia. However, one of our beloved and esteemed friends spoke yesterday, and she's here, and we love her so much, from the Sidney Kimmel Jefferson Cancer Center, Dr. Edith Mitchell. For the last 2 years, Dr. Mitchell has partnered with us to ensure that we would have our PSA screenings, but not only have our PSA screenings, but she also makes sure that follow-up is done, which is extremely important with men who have abnormal numbers. In other words, we call this the interface. In other words, Jefferson said we'll send the letters to the men, we'll follow up with them, coupled with the church's responsibility to do the same thing. And so, Dr. Mitchell, we appreciate you today and for the next time that you assist us, which will be next March. And while I'm on that subject, so I don't forget, March the 10th, 2018, E9 Tabernacle will sponsor its next Know Your Numbers event. And if anyone wants to know how a church does it big and does it right, we invite all of you to come to that event. We're in there 13 hours. You can go to our website, E9Tab, ENONTAB.org. You can look at our Know Your Numbers through YouTube, just Know Your Numbers, and do that. And you can also go on our Facebook page, which says Men of Iron as well. What else is important to us is that over the past 6 years, we have screened over approximately 1,794 men. And what's more significant, I recognize all of the research and all of the advances that are going on now. We certainly appreciate it. But what we said as a church is more important that we know who's within the body of your church. It's not good when a church doesn't know its members except on Sunday. So we asked the question, how is it we can do that? So we formed what we call the E9 Cancer Survivor Support and Caregivers Ministry. Within the confines of this ministry, our mission is to assist individuals with cancer awareness, education. We provide caregiving support. We also go to the doctors with our members for meetings if they don't have a relative or another close significant other with them. What's significant in this particular ministry this year, because of a relationship we have forged with Finn and Mr. Thomas Farrington, we started our support group, which Finn supports. Now, what's even more significant is that while this group is specifically for men with prostate cancer, we had men who had pancreatic cancer, lung cancer, and various other cancers who participate in this group, so we can't turn them away. The idea is that they seek to find out more about prostate cancer since they don't have it, but they have other pieces. We also say to families in the life of our church, because we have a holistic ministry, that families are extremely important in this process. Now, I appreciate Dr. Coleman with her humor, because what happens, men are not only fearful of the needle, but they're also afraid of losing their woman. Many of them. So they might not go to the doctor if it means that they might have to lose their girlfriend or their wife. But we bring in the wives to our groups as well, because it's important, because usually the wives have more questions than the men. Another important fact that I know we didn't bring out too much over the last day was there are many men who are suffering from regret from different procedures or treatments that they have had or currently are in. So we have to deal with the counseling side of that at our church, so we do offer counseling to individuals for that. Also, it's extremely important for us to be clear that education is extremely important, lobbying is extremely important, promoting the idea that men can be healed through this process, yet we live in a tension of the 20% age where the cancer can return. But then we also have to seal what we call the deal, that even in America now, that no man has to be uneducated about what prostate cancer is. We literally bring the researchers to speak to our church members. We bring the doctors in, we bring all of the specialists in to speak to our members, so the interface never changes. But also, in addition, it's important that we speak to the congressional members of Congress. We also interface with those who represent Medicare and Medicaid. We were glad to hear about our representative from the cancer support community, which we have a very large contingent in Philadelphia on Shimoni Drive in the park. We thank again our beloved Dr. Edith Mitchell. We have relationships with Temple University Oncology, Penn Abramson Cancer Center, Fox Chase Cancer Center, Cancer Treatment Centers of America, and also pharmaceutical companies. I was certainly glad, Mr. Farrington, that Bayer was here as well as Pfizer, and we'll be in touch with them because we need the money too. I'm a church member. We need the funding, and we have ways to work that out. And what we generally say at E9 Tabernacle is that if you can get in our boardroom with our pastor and myself and Reverend Miles, who is looking on, that we will convince you that saving the life of an African-American or Afro-Caribbean man who is suffering from prostate cancer is more valuable than you will ever know. And as I said, I would love to leave today with a scripture, which is important, and I know some of you know this through experience, that when men encounter other men, it's extremely important. We speak to men every day, daily, about their challenges. We speak about one big word, it's the T word, it's about trust. One of our problems, not only do men not trust medical facilities and the system as we call it and others, but we have a lack of trust for one another. But what we believe is that when men see other men and believe other men and share with other men the possibilities of being uplifted from whatever their challenge might be, especially like prostate cancer, then we will see a bridge and possibly a nullification around the gap between the myth and the truth, which will lead then to a miracle that they never knew that they could experience. And with that in mind, the book of Proverbs, the 27th chapter and the 17th verse says, and why it's significant that men have to face each other, is that iron sharpens iron. So sharpeneth the countenance of every man. God bless you and God keep you is my prayer. Thank you.
First of all, I would like to say thank you, Mr. Farrington, for the opportunity to present today about our outreach community project and our church partnership with FIN. Today I will talk to you about faith-based prostate cancer support group. The Mitchell Chapel AME Zion Church Prostate Support Group was formed based on the needs identified at a health fair. The church is located in the small town of Pittsboro, North Carolina, with approximately 800 plus members, and our pastor is Reverend Corey D. Little. A survey was conducted after the health fair to verify that the men wanted a prostate cancer support group. The end results was positive, thus the faith-based prostate support group was started. The format for the group is based on the FIN resources, NORBEC's social support questionnaire, and CON's measures of support, social support. Social support consisted of AIDS, which is the financial support, the affect, emotional support, and the positive responses to those with prostate cancer. The group was led by a nursing professor and an environmental research engineer. Both are members with FIN. The group was, one problem that we had was gaining and maintaining the men's trust in sharing and providing their information with each other. Once the trust was gained, the men readily shared their information at each monthly meeting. During the meetings, using the AIDS, the affect, and the affirmation guidelines and a discussion of biblical truths, the men started sharing their stories and explaining their symptoms and experiences from diagnosis to the end of the treatment. They told stories about their masculinity, disturbed body image, and loss of spontaneity and sexual emotion. Some men call this disease a relationship because it affects partners and the survivors' sexual functioning, intimacy, and the quality of life. The wives, girlfriends, and significant others are mentioned as leaders in getting the men to seek medical care. The pastor of the church joined the group at intervals with spiritual guidance, and we also delivered culturally appropriate content for the African American men. They also presented information in simple terms, always remembering privacy and trust. Even though the pastor visited at intervals, all lectures were grounded in Christianity and youthfulness of religion in life. Christianity is important in African American men because it provides comfort, safety, and a sense of belonging by serving a higher power. Each year, the men at the Mitchell Chapel AME Zion Church participated in the rally against prostate cancer on Father's Day. The pastor talks about prostate cancer and then will ask the men to come to the altar for prayer. All the men in the church, prostate cancer survivors and family members, are recognized and join hands in a special prayer for healing and support. Church background. How is the church working with FIN? We are members of the Mitchell Chapel AME Zion Church. Dr. Sonia Wilson, who works with me, is a member of the FIN Advisory Board. And myself, Lillian Alston, we're both FIN ambassadors. The men and the prostate cancer events, such as the North Carolina Coalition for Prostate Cancer, Mr. Farrington Prostate Cancer Symposiums, discussions, and the men's retreat, were over 800 men in attendance. The impact of FIN on our church has been, we have mobilized between 50 and 800 African American men in North Carolina in the AME Zion Church. We have consulted with a Holy Church, an AME church, and a Baptist church. Annually, the leaders of this prostate cancer support group would share the current research on prostate cancer from the summit here on Capitol Hill. The partnership on our congregation and community has been with local church groups, the Chatham County Health Department, Chatham County Hospitals, Blue Cross Blue Shield, and the fire department. And finally, I would like to end by saying we were consulted by other churches to bring prostate cancer support group to their churches. And just last week, we both, Dr. Wilson and I, presented at an AME church and a Baptist church. And after our presentations, both churches wanted to start their own prostate cancer support group. So in the process of maintaining and obtaining that information for those churches, we have now met with the urologist within that town, a cancer specialist, and medical doctors to help those churches set up their support groups. And lastly, expand on prostate cancer awareness. We are reaching out to the churches other than our AME Zion churches. Thank you.
Again, my name is Deacon Donald Chambers, but before I want to give acknowledgement one more time for Mr. Farrington. Well, my story's a little bit different. I'm a deacon, and at my church, we truly do care about people. It started off in 2014 when my pastor, Dr. Lansteen Watson, I am from St. Paul's. When I first started there about 23 years ago, we had 500 people. Now we have 10,000. And we are still growing throughout Central Virginia. In that summer of 2014, Pastor Watson, before he delivered his sermon, he came to the pulpit and we looked with amazement because this time he wasn't preaching a sermon. He shared a story. And the story was about him. He said for a whole year, he walked around with prostate cancer. He said that he was very concerned, he was very afraid, because in his family, he's seen both parents, father and mother, that has been affected by this disease. Not only his mother and father, but both grandparents have been affected by this disease. Not only grandparents and parents, but 3 of his siblings have been affected by this disease. He said something so incredible that morning that really got me thinking. He said that he was afraid. Here's our mighty pastor that delivers a sermon to 10,000 people, that's on BET and pretty much speaks around the country. But he was afraid. It started our men's ministry thinking at St. Paul's Baptist Church. Something must be done in our community. And I thank God for Pastor Watson, the God in him, for reaching out to Finn, because they have changed the course of our whole health care when it comes to prostate. They've been at our church for over 4 years, and I will tell you this, over 4 years, we've had probably about 4 to 5 men that I know personally that was able to go to the doctor to get their checkups, and they are now surviving, because what Finn did was it gave them the knowledge, and with knowledge it gave them the understanding that they are not in it alone. At our little church, we have a saying that God is with you and we're never alone. So now we have developed a support group for these men. Not just any support group. This support group will gird up beside that man and walk with him through the entire process. Being a deacon, yes, there is a spiritual part that plays in this, and the spiritual part we are just learning about. I've been with the Barnabas Counseling Ministry now for almost 15 years. I have seen probably hundreds of men that have come through just my support group. But there's one element of our group that we didn't have, that Finn has helped us with, and that's the whole prostate cancer. It is so, so important. So here I am. I'm not a public speaker or anything. I shared with our men's group that I was going to Washington, D.C., and they were like, for the cancer, prostate cancer with Finn? I said, yes. And they said, man, you are so gung-ho. I am gung-ho. I am gung-ho about learning what can we do in our community. Every single life matters. So I'm going to gird up beside the hundreds of brothers that we have in Richmond, Virginia, and we're going to do something. But again, I thank God for Finn. They have just given us the tools that we need. This is such an awesome, awesome organization. And I can't even say thank you enough, Mr. Farrington. When the men come into the support group, the first thing that I hear, the number one thing that I hear is this: man, I'm going to die. The enemy has already planted those seeds in your mind. So the spiritual part is so important. There's a scripture in James that says to count it all joy, my brothers and sisters, that you're going to face trials of many kinds, but it's the testing of your faith that must endure, and endurance must finish her race so that you can be mature and complete, not lacking for anything. For if any of you need knowledge, you ask him for it, and he will give it to you. He will give it to you. But you must believe. You must not be like the waves of a double-minded man, for a double-minded man gets nothing. This is the greatest fight of your life when it comes to prostate cancer. I believe not only with scripture and faith, but I believe with the knowledge piece. Getting the knowledge so that you can get the understanding of better taking care of yourself. Those brothers that have come to me with tears in their eyes saying, Deacon Chambers, I am so grateful that I showed up at a FIN event. There's so many obstacles. And one of the obstacles that we face is, yes, it's trust. Because I've been hurt in the past by a doctor. I don't feel like it's necessary for me to go to the doctor. I'm a man's man. I can handle it all by myself. No. There was somebody who helped bring you into this world. And there will be people along the way that will guide you through. None of us is in it by ourselves. The other thing they share with me is about their relationship. Will my wife leave me? Will my girlfriend leave me? But with the education that Finn has offered St. Paul's Baptist Church is truly remarkable, because not only that they have saved relationships, but they have saved families, because these men go on to have families. In the Barnabas ministry, pretty much what my role has been for the last couple of years is that men come to our group because they're broken. And the number one thing that we do is to help them to renew their minds. As I shared with you in James, guess what? We're going to have those troubles. Hey, these are the cards that are dealt. Now let's deal with them. Because I believe with everything that I have that God is a healer. Yeah. And as we're getting more information for our church to build an awesome support group, we have three campuses in our church. One is on the south side of Richmond, the other one in Petersburg, Virginia. And I imagine in the next year or so, what we're going to do to save lives in our community with Finn is going to be incredible. We talked about sinners coming to the church and hospitals and doctors partnering up with St. Paul's. We talk about not even having a support group in the church, but having smaller groups outside of the church. We not only want to deal with just our community, but we want to deal with our entire state. We are in it for the long haul, and I thank God that Finn and brothers like Tom Farrington have helped save lives. May God continue to bless you and be with you.
While he's getting that ready, I'm the new member on the team, so I guess I'm the rookie to Coach Farrington now. I brought a great friend and a mentor of mine, and she's going to talk to you about how AARP benefited from our partnership. And after that, I'm going to go into why I'm so excited to be a part of Finn and tell you a little bit about what I've done over the years. So if you would, welcome my mentor and my great friend. She's over the state of Georgia for AARP, Ms. Deborah Tyler Horton.
good morning.
Good morning.
God is good.
Yes, he is.
Weather's beautiful in D.C. All right. I'm Deborah Tyler Horton, and I am AARP Georgia State Director, and by North Carolina, because I started out in North Carolina with AARP. I am so pleased to be here to just share with you for a moment the experience we had with G. Davis Production. So AARP, about 7 years ago, started a faith-based outreach, community outreach program. And I was very fortunate to join AARP at that time at the initiation of that initiative. And of course, I've heard it all through. I've been here since you started this morning at 9, sitting back there quietly. But what I heard is we have to go to the communities. That is a fact. AARP had felt they had kind of missed the mark on, you know, the outreach, but not going into the community and taking the information to communities, especially for our African American communities. So everybody in this room has heard of AARP. And so probably if I said, what did you know about AARP, you'd probably say our programs and our discounts, right? But AARP has such a wealth of information on programs that we needed to get in the hands of communities. A primary program that we offer is about Prepare to Care. And that is everything that we've talked about here today. We have to help our families prepare to care before there's a crisis. So we partnered with G. Davis Production in a very unique situation that was unique to AARP. We'd never done anything like this. I sat down with Mr. Davis with our materials and tools about preparing to care, and he wrote a play called Mama's Girls. For 6 years, we started out in North Carolina, and for 6 years, he traveled the country. The play Mama's Girls had become one of the most sought out events through AARP to bring to the faith community our caregiving outreach materials. So I also heard from this side over here that, you know, we need resources. Well, AARP is a partner. AARP is in every state, so you need to look them up. But we come to the table, everything is free. We bring the materials, we bring the tools, we bring some dollars to the table to work with our partners on these initiatives. So a production like Mama's Girls, which was fun and exciting, come into the faith community where our faith ministries need to connect on health. What better place to take the health message than into the church? I'm an ordained deacon, so I understand what it means to bring this to the churches. Every church has a senior ministry. Connect with the ministries, connect with the pastors, the opportunity, the reality of, I can't remember if you said, but when we go into our communities, if we ask people to come to an AARP event, it's a little different. But when I go to Poplar Springs Christian Church in North Carolina, and I bring the play Mama's Girls to talk about caregiving, it changes lives. This partnership helped us reach thousands of individuals and help change people's lives if they begin to think about how do you prepare to care. There are 1.3 million caregivers in the state of Georgia. Now, how am I going to reach those individuals with my staff of 11? I have to partner with the faith community and volunteers to take this message. The play was exciting. It was fun. People saw themselves in the characters of the play. And he's going to show you some great things here on the screen that's really going to get you excited. And it really was unique for AARP. We were so excited. We can't wait for the next project with G. Davis Productions. And I'm looking forward to working with you all on this one. So you know how to reach me. But and I know he will. But this is great. This is a great opportunity for the faith community. It's a great opportunity for our communities. They need the information. We can partner with you, provide the resources, the materials that you need. But we have to go in a different way. The play was a very unique and different approach. People got excited about having something like that come to their churches, come to their communities, and at the same time, they benefit enormously. So I want to thank you for letting me jump in here really quick. I've got to go to another event. AARP's resources, information, every state across the country. Deborah Tyler Horton, AARP State Director, Atlanta, told you to call them. Amen. Amen. Y'all have a wonderful day.
Thank you, Deborah. I'll find the mouse up here. There you go. I got it. I think I got it. I'm so used to dealing with a Mac. So how did I get here? I'm a grandmama's boy. My grandmother raised me. My grandmother's name was Goodness. And I went home from spring break, and Goodness didn't know who I was. I didn't know how to deal with that. And so I did as most young people do. I ran away from responsibility, and I didn't go back into the funeral. And it was years later that my mother and my sisters and my aunts would tell me, you know, Goodness would ask about you. And so now I'm feeling bad. So what do I do? And so I'm a playwright. So I wrote a play to kind of release some tension. And I was just going to do this play one weekend in Winston-Salem, North Carolina. 47 days later, people were still coming to see this play called Forget Me Not. And so I dove into Forget Me Not because I wanted to know what took my grandmother away. So I believe you can't treat people the same. You have to treat people fair. If you treat people the same, somebody's going to get left out. And so what I call the unreached people groups, that's the African Americans, because every corporation is trying to reach the African Americans, because you got to jump through hoops, they say, to reach through African Americans. Well, I'm willing to jump. When I found out African Americans were twice as likely to get Alzheimer's disease, I went to the Alzheimer's Association. I said, okay, you need to be in my community. And so I'm not bashing the Alzheimer's Association, but when they wasn't in my community telling me enough about what I think my community need to know, but they wanted me to walk, I said, before I give you money to walk, you need to tell me why I'm walking. And so I went to the Honorable, I went to Al Sharpton, I went to the former Dr. Satcher, and we started the African American Network Against Alzheimer's Disease. Because if we're going to reach our people, I think our people need to see us giving them the information. That's just my way of thinking. And so when we started that, we began to let people know that there are things that's going to hurt and harm you based on your lack of knowledge. Because I believe our people do perish for a lack of knowledge, but I also believe those that hear the knowledge and do nothing speed up that process. Right. So once you hear this knowledge, what are you going to do with it? So I began to think that our people learn differently. So I said, I'm going to write a play about 5 sisters from 5 different cities trying to take care of their aging mother in the midst of family drama. And so how do you become a caregiver? You get a call in the middle of the night. They said, meet me at the hospital, your mama failed. And then the doctor says it's a little bit more serious than I thought. So somebody's going to have to take care of mama. You know who ends up taking care of mama? Whoever lives closest to mama. And your other sisters call you and tell you what to do. That's what happens in our culture. And so that's why Mama's Girls was so successful, because it was real. People could see themselves on stage. The average life expectancy of any stage play is about 1.5 years. We've been touring Mama's Girls for 7 years come next year. But let's get back to Forget Me Not. Forget Me Not come next year. We've been touring for 10 years. 10 years traveling the country. I called my good friend Bernadette Standish from Good Times, Thelma. At the time, her mother was going through Alzheimer's disease. Her mother succumbed to the disease Alzheimer's. So we started using entertainment as a way to draw people. And when we did that, once we drew them there and entertained them, we turned it over to the professionals. That's why I'm excited about working with Finn. We're going to draw people with a play called Daddy's Boys. Wow. So I did a play called Daddy's Boys because I didn't find out who my father was until I was 16. And so I wanted to show how important it is for men to be in the lives of their children. Right. But then my manager said, we got a conference call with Thomas Farrington. I said, well, who is he? She said, he's with Finn. I said, what is that? She said, the Prostate Health Education Network. I said, okay, and that is what? So I got on the phone with Thomas, and before I knew it, I said, I'm going to incorporate, I said, I'm willing to incorporate something about prostate health in this play called Daddy's Boys, because you've reached me. I think it's important. I said, just send me some notes so I can incorporate it. Well, I sent him the play. Guess what? He didn't send me back notes. He'd already rearranged the script and told me and who was going to say this and who was going to say that. So I said, okay, he's speeding this process up. So we're excited that on October the 9th in Fayetteville, North Carolina, we're going to release Daddy's Boys in front of about 1,500 people. 1,500 people. Because we've been touring the country I've been doing this for 23 years. But the last 6 years, I found my niche. And that is going into these communities of color, raising the awareness of these issues in a very unique way. We did Mama's Girls in front of 3,000 people at the AME Zion Conference. We did Mama's Girls at the National Baptist Congress, 5,000 people. It's not about big numbers. We've done it for 200 and 300. But everybody that came to see that play saw it for free. Because we're not letting money be an issue while you can't see this. We want you to come see this. So this is my philosophy. If I can change the way you feel, I can change the way you think. If I can change the way you think, I can change the way you behave. And if I can change the way you behave, then we can move somewhere. But what happens is all this information gets out and it goes over people's head. So I like to take what Thomas has given me in a very creative way. So when they leave that play, you know what? I need to go get checked out. You know what? I need to talk to my wife about this. That's what it's all about. I will get the people there. That's what we're trained to do. We get the people there, we entertain them, but then we turn it over to you, the professionals, and lead you to a place where they can get help. So this video I'm about to show you is what we did with Forget Me Not. One of my partners is Emory University in Atlanta. So we all know, I'm talking to a room of educated professionals in your field. Less than 3% of people participate in clinical trials if you're of color. So how do you get people to participate in clinical trials? The first thing I do is I talk about the elephant in the room, Tuskegee. I partner with Wake Forest Baptist Medical Center. There are 3 African-American research centers on Alzheimer's disease in the country. I consult for one of them. And so when I go around to churches, I start off with Tuskegee. Okay, and because of Tuskegee, this is where we are now. That'll probably never, ever happen again. You've got to address the issues first before you can teach me how to fish, and then you follow. And so when we do that, it's a difference. So we did Forget Me Not in Atlanta, Georgia, and 1,000 people. We had 131 people sign up for clinical trials. Wow. 131 sign up for clinical trials after seeing a play. You're not going to tell me. That's right. You're not going to tell me a man who has prostate cancer, whose daddy had prostate cancer, who started an organization like Finn, who's going to partner with us, that we're not going to change. See, I'm just crazy enough to believe that we can change the world. Yeah. So I'm going to show you this video. I got to get used to working this. I'm going to show you this video. I'm just not used to, here we go. Did my, let's see. So here's the video I want to show you. Between our production, there are 52 weekends in a year. We probably do about 45 weekends a year, not including some weekdays, traveling the country, from Alzheimer's disease with the Us Against Alzheimer's, Mama's Girls with the American Diabetes Association. We have a play on diabetes. We also have a play on bipolar disorder, partnered with the Wake Forest Baptist Hospital. We're working on a play on teen pregnancy. So all the plays that I do are centered around some type of issue that affects our community. So this is why what I do, and I'm excited to be working with Finn. So take a look at this.
Good morning. There is a certain excitement at Antioch Lithonia Missionary Baptist Church.
We're deciding to get another rush of
I guess it has to buffer all the way through first.
Good morning. There is a certain excitement at Antioch Lithonia Missionary Baptist Church.
We're starting to get another rush of people in.
An impressive turnout for a different sort of message.
The more I teach him, the dumber I get.
The laughter of 1,000 people quickly fades as a story on their church's stage takes an unexpected turn.
We got poor reception. Just internet service.
Forget-me-not dramatizes what happens in most families when somebody is affected with a dementing disorder.
The play Forget-Me-Not. The play Forget.
Okay, so it's got to load for halfway, so I'll talk to you about something for about 2 minutes, then we'll get back to that. So what you're about to see is a play, Forget-Me-Not, that I did with Emory University. And we brought the play, now, in the course of a day, we let our host decide what that day looks like. And so in the mornings from 9 to 10, they did a short breakfast, and they had a speaker to talk about how Alzheimer's is affecting your community, how Alzheimer's is affecting your church, how it's affecting your immediate family. And we had resource agencies from all over Atlanta there to give out free information about certain things, starting support groups. And so we had a session for how Alzheimer's will affect your church. And so if I'm sitting in church and my dad has Alzheimer's disease, and he gets up in the middle of the service and says, I'm ready to go home, you look at me funny. And then I don't go back to the very place I've been going all my life because I don't feel comfortable. And so you see me in the grocery store, where's Brother Davis? Well, Brother Davis is at home taking care of his daddy. Well, Brother Davis needs more than prayer. Brother Davis needs a support group. And a lot of times the churches don't know how to deal with this. And so one of the things that we like to offer is consultations with the churches to let them know how to deal with a disease such as Alzheimer's disease. Very few people know the difference between Alzheimer's and dementia. They think it's the same thing. And so you can't deal with something if you don't know what you're dealing with. And so this was part of the day that we do in terms of the day with Forget-Me-Not. So hopefully we can get through this now. Let's try it again.
Good morning. There is a certain excitement at Antioch Lithonia Missionary Baptist Church.
We're starting to get another rush of people in.
An impressive turnout for a different sort of message.
The more I teach him, the dumber I get.
The laughter of 1,000 people quickly fades as a story on their church's stage takes an unexpected turn.
So there's a clinical trial for dementia and Alzheimer's, and I think that would be a good candidate.
Forget-me-not dramatizes what happens in most families when somebody is affected with a dementing disorder.
The play Forget-Me-Not is an outside-the-box attempt from Emory Brain Health Center to reach an at-risk group. African Americans are twice as likely to get Alzheimer's, but less likely to get help.
We want them to not do certain things, and that is to ignore the behaviors and think that they're going to go away.
Emory Brain Health Center's sponsorship of the play is a way to start a conversation that will hopefully lead to a relationship.
We wanted to come where we felt we could make an impact in a population that we really desperately needed to reach.
I think I'm going to go over to Emory.
This is the most difficult thing I've ever done.
And my best friend.
Garrett Davis wrote this play for his grandmother, whose name was Goodness.
Goodness was the apple of my eye, and I was the apple of hers. And when I went home from spring break and she didn't know who I was, I couldn't deal with that. Excuse me, I couldn't stand to see her like that. And so I didn't go back into the funeral.
The play and his role as June, the charismatic grandfather in the grip of Alzheimer's, is his gift to goodness.
This is how I make up for it. This is how I give back. This is how, if someone else, who may be in my shoes, they'll handle it differently after seeing the play.
So mixed in with the laughter and the pain is a request to join research.
Different diseases manifest differently in different people. Research is not a fearful kind of thing.
If you log into that website and you answer a couple of questions, you are now a research participant.
I would hate for us to come up with a cure for Alzheimer's disease and it doesn't work in us because we didn't take part in clinical trials.
The emotion on stage
I'm 69.
has made an impact by intermission.
I think black men have this real fear of hearing the truth. There's this macho thing.
Thomas Goins and his wife Sylvia say they're in.
My husband and I talked about it already, and so we're going to participate.
An unusual trip to church for a group asked to join a movement, one that will help maintain memories.
I'm sure she's smiling. I do everything for goodness sake.
I'm Jay Watson for Emory Brain Health Center.
So in conclusion, can you imagine a play on prostate cancer? Changing the way men look at certain situations? Because a lot of times we have to see it in an open arena. It's going to be powerful, and I thank you for your time.
Thank you. I want to thank all the presenters, and real quickly, we're going to open the floor up for questions, but let me just give you an idea, because this is the enhancement of what we're doing. Just give you some percentages that we're looking at. Because of the symposium that we've had across the country, that's what I'll do it from here, I'm fine. When we talk about were people satisfied with the topics and the presenters, we're talking about a 90% rate of what we've done with all of these fine people here and other churches. When we start talking about increased knowledge, when they took the surveys, we're talking about a 92% increased rate in terms of people understanding and felt I left with information. When we're talking about the organization of the symposium, the way it was done, we were about 94%, and will you come again? That's about 90%. So we're trying to go to a straight 101%. And this is what we have. At this time, any questions that we have for all of our participants, and from symposiums to the network? Yes, we have one right here. If you can come to the mic, please. And thank you all. They're wonderful.
Ladies and gentlemen, I thank you very much for being here. And I just wanted to make a mention about this thing we talked about, you mentioned earlier about fear and the psychology of the prostate cancer. My grandfather, I was a little boy, and my grandfather passed away from prostate cancer. And I used to lay awake at night listening to my grandfather moan and groan, and I didn't know what the problem was until I got older and I found out he had passed away from prostate cancer. I just came home from school one day and my grandfather was gone. I didn't see him anymore until I was at the funeral home looking at his casket. And that took a lot out of me. So when I found out I had prostate cancer, when I got my diagnosis, it brought me down. It brought me way down. I couldn't sleep, couldn't eat, and the enemy really started playing on my mind. I became suicidal. And had not it been for my faith that I had and some of the things that I had gone through that time, because it really played on me, because I had lost 3 friends within 6 months in that year of 2006. I lost my best friend from high school I played ball with from a heart attack. I lost my girlfriend to breast cancer because she didn't go to the doctor. And another very good friend who was a warrior right here in Washington, D.C., his name was Damu Smith. I don't know if anybody remembers Damu Smith or not. He passed away in 2006. All of this happened. And there I am on the highway coming back from Michigan, where I went to bury my friend, and I heard about Damu. And it brought me down. So after I was diagnosed with prostate cancer, I decided, well, you know what? You can't really go down too much further with this thing, so you know you got to go up. It's the only way you can go is go up. And this is the thing that keeps me going right now with the work that I do and that I have done in Jamaica for the last 8 years, because it's been very difficult to get out in the hot sun and deal with the brothers in the street, you know, in the beer joint, the rum joints, the bus parks, bus stations, and things that I go when we go with my team and we talk to the men about being screened for prostate cancer. So this is what's really, really so important, is the psychology of this thing and how it plays on you. And it still affects me today. And I'm 10 years cancer free. 0 PSA. Okay? 0 PSA, and testosterone is close to 500. Now, I don't know, Doc. I mean, you know,
so,
am I something special?
Yeah.
Yes, am I something different? That's a good thing. Okay. Now, the question here is this. You know, how can we take all of the things that we've experienced here? This has been a wonderful weekend of activities. But I know we're going to be hooking this thing up back in the communities and so forth. But the concentration, I think, has to be to a large degree about the focus and the mind and the faith and how we continue to really develop that. Because I'm really interested in the church aspect of it.
Yes.
Believe me, I am. Okay. So that's my question to the group here. You know, how you know, what can we do to continue this faith-based aspect of it and include the psychology of prostate cancer, if there is such a thing, the psychology of prostate cancer or being diagnosed with prostate cancer. What's the psychology of that and how that affects black men?
Can I get a comment from each of you about how you work, just briefly, because we're with time, just how you work with this mental aspect with the spiritual? Have you had that experience? So quickly, if you can share that in response to him, and then we'll have one more question. Yeah.
I think spiritually is renewing your mind. You know, and I go back to scripture again, Romans 12:2 talks about renewing your mind. And you have to eat different. You have to think different, you know, and I believe that that is a strong component. And then having a circle of believers that surround you, a support group, to help you, to guide you through the process.
Okay. You have anything, Gary?
If his church has the answers, they have to make sure that they're welcoming the people there to get the information. So I know these churches have the answers. I think the churches also need to concentrate on making sure that the doors are open to whoever it is, because, you know, so they say men don't like to talk. When men have those conversations, they'll tell you things, but they got to feel comfortable talking.
Okay, thank you. You have.
And I would like, can you hear me? Okay. I would like to say that providing that spiritual guidance, providing that trust, maintaining that privacy within the men so that they can move forward, focus in all aspects.
Thank you, Reverend Newberry.
Yeah, and as Brother David said, we're a church. We're open 7 days a week, morning, noon, and night. Be available, enrich your men's ministry, and always have an open heart for interface. Men have to talk to men. They have to see men, and they'll know a man's heart.
Yeah, very quickly before we go into it too, is because there are two ministries. One is a mental health ministry. That's one thing that we're behind. That was one of those less than 10%. And then the other would be the actual health ministries themselves, having these organizations do both, because you have the spiritual and the mental health. Right quick, thank you so much.
Hello, good day. Patrick Lindsay out of Detroit, Michigan. Thank you, and Finn, for all you all do. To the churches, how significant of a line item is it on your budget for these kinds of activities, health-related? And number two, do you partner with smaller churches who may not have the capacity to bring about the critical mass to do some of these things? Do you partner in your communities with smaller churches?
Right. So we're the largest church in Philadelphia and the state of Pennsylvania. So our pastor's objective is that we while we're open 7 days a week, the important factor is, number one, that we're open to the community at large, regardless of your religion, regardless of your culture. So that's extremely important for us, and we'll go anywhere to help anybody. So that's one. Number two, budgetarily, that's high in terms of our church. That's a high mark. Yeah.
I want to comment in terms of the churches that have, if you're a mega church, everyone wants to get into your church because you got a lot of members. But just because someone sits in a table and 5,000 people walk by your table doesn't mean they got the information. It's important that you develop relationships with these resource agencies. So if the hospital wants to get into your church, you need to let that hospital know we need a relationship with you. So you're just not here one time, but you're here on a continual basis, so that when my parishioners have a problem, I can feel comfortable pointing them in your direction.
Okay.
And again, my pastor have been affected by this disease, so it's very high on our list. The second thing is monies. We're always looking for monies and partnerships.
All right, is that it? One last question, and then
I promise I'll be brief. Two things that were mentioned, both Reverend Newberry and Deacon Chambers mentioned church events. I just want to say that nutrition, eating properly, is very important. We have these church events, and we have church punch and all this other kind of stuff, and it's very important for prevention, continued care, and to reverse some conditions, nutrition, especially at church events. And the second thing I want to say, I'm a deacon at my church, and I believe we should go out into all the world and preach. And I just want to know, has there been any outreach to mosques? Because those are very important things. Yeah. Thank you.
Yeah, well, for us, because Philadelphia, if you know the history, and currently we are per capita the #1 city in America with more Muslims than any others. So it's important that we do partner. It's significant that we do have a difference in terms of our polity. But the last time I checked, Muslim men, African American men, also suffer from prostate cancer. So we do partner with the other groups. Also, just on my sister's point about nutrition and health, we can talk about prostate cancer, but we suffer from many other diseases. So it's important for us as a church, from A to Z, we have pretty much any health event that you want to take part in. We have nutrition classes, registered dietitians, and even if you want to learn self-defense, we have our own dojo. If you want to learn how to fight, because that's all about discipline, but we do it to help the mental focus and the physical nature of individuals.
Is anybody else?
Well, we have over like 70 small groups, and that's in Richmond, Virginia. We don't have such a large population of Muslims, but we do have a large population of our Mexicans, brothers and sisters on the south side of Richmond. So definitely there has been an outreach to that community.
I would also like to add that Finn, and this will be next week, Congresswoman Kelly's office worked very closely with Mr. Farrington on this issue of clinical trials. And this month, they've asked Finn to actually be featured in her newsletter broadsheet. And that's going to over 1,000 agencies across the country. The question about the mosques came up because we're looking to see wherever you are to be served. And that was a big issue, certainly in the Chicago area. Is there any, Mr. Farrington said, I have a few more questions. You have one, please come to the mic. Have a little more time. Thank you.
Thank you, Brother Davis, for the work that you're doing. Great stuff. In Fayetteville, where will it be? Will it be open to the public? I want to drive down there and see you.
It's going to be at Kingdom Impact Global Ministries. I'll give you my card. Brittany will give you my card, and we'll get you that. But it's free and open to the public.
Okay.
And last count, there were over 1,000, so the church only seats 2,000, but you have to have a ticket to get in. But I'll make sure, if you're driving, I'll make sure and your colleagues are there.
2 tickets, please. I'll be there. Congratulations.
Are there any other questions for this session for our great panelists here? If not, let's give them a big round of applause for what they've done. Thank you and their efforts. Thank you very much. That ends our session.
You got mine.
Let's give Adrian and the panelists another round of applause. Now, don't go anywhere because we're not finished. I want to say that I've had the opportunity to work with these churches, and it's quite a pleasure because we have to get the message out. We have to get to the communities, and as I said, we organized our faith-based initiative starting in 2009. And Reverend Watson has, joined our FIN network once he was diagnosed with prostate cancer. And we've just been fortunate to be able to come to St. Paul's and to work with you all. We look forward to continuing to do that. We just began our relationship with Enon, and we're looking for some great things with Enon in the future. I know that Mitchell has been with us, and we've been working with Mitchell since the very beginning. Pittsburgh's a small town next to Chapel Hill, where I'm from, and so we've had great response there. And we're just excited about being able to work with Garrett Davis. When I saw his play, saw the clip that you saw, I said, well, hey, this certainly can be translated into for prostate cancer. And when he sent me the script for Daddy's Boys, he said, I read the script. I said, oh my God, we can do something with this. And he said, well, make some notes. Well, I looked at it and I said, I don't know how to make notes for a play. I've never done that. And I asked him in the beginning, I said, now you're going to be open. I said, I'm not really trying to rewrite the play, but I'm going to do a few things here. And he was very, very gracious. So we're looking forward to seeing this on October the 9th. And we'll see how many people are able to go there with us. And then we're looking to roll this out across the country. We're looking to roll it out at Enon, St. Paul, other churches, and around the country. We'll do something in North Carolina with Mitchell Chapel. Somebody asked a question about small churches. We work with churches of all sizes. At our very first Father's Day rally in 2009, I happened not to be in Boston. I was in West Virginia, trying to think of the name of the retreat. And so there were no black churches. We had no partners there. So our closest church partner was in Roanoke, Virginia. And I drove from West Virginia to Roanoke, Virginia, ran over deer, and had one of the most delightful experience with a church of about 50 people. That was our closest church. And what I learned from that is that all the members of all the churches, regardless of size, go through the very same thing, have the very same challenges. And I know that we can make an impact with churches regardless of how large or how small they are. So I'm inviting all churches to join us. For those who are listening in, please join FIN for all of our faith-based initiatives. So at this point, I want to thank you again, and we have this is you, Adrian. And this young lady does a good job. She keeps these in the right order. Otherwise, I would really be lost. If I can figure out how to. Okay. All right. Thank you so much. Ms. Davis, thank you. We have a lot of North Carolinians up here. It's not because I'm from North Carolina. It's just that it seems that people from North Carolina do very creative things. So Garrett is from North Carolina, and Mr. Dewberry went to school in North Carolina. Yes. So can we get a picture? Yes, sir. All right.
Come on towards the center, please.
Let me see if I can get on the middle line. Okay. Okay. Thank you all.